are here this morning. I'm very humbled to share this morning's scientific session. We are privileged we'll be privileged to listen to some of our erudite scholars and researchers who will be presenting the findings of their research work and scholarly work. We believe these presentations will add to the existing body of knowledge and also stimulate meaningful scientific discussions and contribute to improving the quality of management of our patients with the overall safety, because we're always talking of patient safety. So as we listen, we have 8 presentations to be done this morning. 2 will be online and 6 will be physically done. In no particular order, I want to invite Dr. Danagogo, who will be presenting. In lieu that he's not here, I'm calling on Dr. Joe to come and do the presentation. They will be presenting, they have 3 papers to be presenting this morning. They'll be presenting on socio-economic influences on critical care delivery. An outcome in a hospital in southern Nigeria. It is a prospective observational study. Their second presentations will be saving lives against the odds, neurocritical care success in a resource-constrained environment. Then the last of their presentation will be acute stroke outcomes in public and private intensive care units. It is a 2-year comparative cohort studies. After them, Omoni and Co will also do justice to their own research work, which is level of bilirubin and outcome in patients admitted in intensive care unit. Is also a single center retrospective observational study. They also do fluid management practices and outcomes in intensive care unit patients with sepsis in a low resource setting. The last of the physical presenters will be Kate Edinohon. She will be presenting acute cerebral syndrome with transient blindness, sensorineural hearing loss. Anticipated prolonged mechanical ventilation is also a case report. Then Dr. Ijoma Ekwedike, Emedike Anwa will also be presenting virtually the cost of intensive care management of hypertensive and diabetic patients with kidney failure and acute respiratory disease syndrome and hemorrhagic stroke, a case report from a resource-rich setting. And also percutaneous tracheostomy as a facilitator of weaning from anticipated prolonged mechanical ventilation, also a case report. During the course of this presentation, I humbly request that each presenters have 8 minutes to do justice to their presentations. At the end of 5 minutes, we'll send out a reminder to them that 3 minutes will be remaining. So with this, I believe we are going to have a stimulating and scintillating, robust presentations this morning. So I'm calling on the first speaker, Dr. Dana Gogo, to come and do justice to her research work. At the end of these presentations, there will be awards given to the best male presenter and the best female presenter.
Is the final prize for
international neurocritical, right?
There's no resident presenting. We don't have resident presenting.
That's the case presentation.
Okay. Okay, in lieu of that, we'll have prizes for the best resident presenter, and then secondly to the best consultant presenter. Thank you all.
Oh, I got information that they're all from no. So best residents and best.
Okay.
So try the pointer back, sneak back, and forth, back first. And back. So start from beginning.
Good morning, everyone. Standing on existing protocol, I'm Dr. Danagogo from University of Port Harcourt Teaching Hospital. I'll be presenting socio-economic influences on critical care delivery and outcomes in a hospital in southern Nigeria. It's a retrospective study. These are my outlines. For the background, critical care, as we all know, is an expensive mode of care for any patient coming to the hospital, and which is worse in lower and middle income countries because of a reduction in the socioeconomic status, and because of its true out-of-pocket payment, unlike other countries where they have national insurance. And this study will evaluate the social economic influence on ICU care. The objective is to assess the effect of socioeconomic status on ICU access and to describe ICU costs and outcomes. It's a retrospective study. It was done over a year of 2024 to 2025, and 143 ICU admissions were used to assess for this study. And the variables are the cost, the rebates, the length of stay, outcome, with then the admission fee was 70,000. And daily charges were 10,000 for non-ventilated patients and 12,000 for ventilated patients. The duration of stay was between 1 week to 120 days, with 91 patients who during the course of admission and after mortality, or they were transferred to the ward, they requested for rebates, which is about 63.6%, with a mean cost for these patients for over 24 hours was 246,000. Total bill were about 953,000, and a mean rebate for them were about 582,000, with a mortality rate about 58.7%, which is 84 patients out of 143 patients. This is the pie chart. Then a high rebate demand was observed due to this economic hardship, knowing that now the minimum wage is about 70,000. So imagine a family where the minimum wage of their salary is 70,000, and for them to pay an admission fee of 70,000, and that with daily charges of 10,000, and a lot of them were having challenges paying. Whenever investigations were requested for or drugs were to be given, they could not pay for it, and this will cause a delay in treatment, which will also increase the risk of mortality in these patients. So in conclusion, socioeconomic factors substantially influence the access to critical care. Policy reforms such as health insurance and financial support mechanisms, unlike the out-of-pocket expenditure, will be needed to reduce this catastrophic healthcare expenditure. My limitations were: one, it's a single center study, retrospective, therefore collection of data is also going to be difficult, and therefore these findings may not be taken for a general conclusion. Then the recommendation is: one, expand health insurance. This can be done either by the increase in government funding or by private sectors supporting critically ill patients. Thank you.
Thank you. Clap for her. You did it under 4 minutes. So that's a very good one. Can you proceed with the second?
Yes.
The second one is sepsis.
Acute stroke outcomes.
critical. Yeah, I know. I just want to open that one way so that it will flow.
Just see.
Acute stroke, right? So I'm coming, please. Sorry. Acute stroke.
Before then, at the end of this presentation, we'll entertain questions and answers. So I think it will be better for us to wait at the end so that if you have any questions, you can direct it to the presenter.
You have to bring your own microphone. It's not going to.
Thank you.
Talk to your executive electronics. So you can't use one because we always do. We can't be passing my phone there is a second one. Unless you go with the first one. But let's see if we're going to manage it. This one now is a small one. You have to raise your. So you want to bring the one that we manage this. So this one.
Okay, like I said before, we also have virtual participants following us online. So what we said is that at the end of the entire presentation, there will be room for questions and answers. So those online, drop your question at the chat box and we'll do, the presenters will do justice to it. And those of us here physically, direct your questions to the presenter and he will do justice to it. Thank you. Let's listen to Dr. Danagogo for her second presentation.
Thank you, sir. So I'll also be presenting acute stroke outcomes in public and private intensive care units. It's a 2-year comparative cohort study for Southern Nigeria. With a brag on, a stroke is a major cause of intensive care admission, disability, and mortality worldwide. In Nigeria, differences in healthcare access, timeliness of intervention, and availability of critical care resources may significantly influence patient outcomes. With this aim, my aim was to achieve the clinical characteristics, time to presentation, outcomes of acute stroke patients admitted to a private and public intensive care unit in Port Harcourt. It was also a retrospective comparative cohort study with 91 stroke patients. The duration was between January 2024 to 2026, comparing between University of Port Harcourt Teaching Hospital as a public and the private was Prime Medical Consultant Hospital. The demographics, characteristics, time from symptom onset to hospital presentation, and clinical outcomes were analyzed with the primary outcome, which is comparison in survival and the ICU mortality. The results were 60 patients were analyzed from the public ICU, knowing that more patients go to the public ICU due to cost, and 31 patients to the private ICU with a mean age of 53 years. The marked differences were observed in healthcare seeking behavior and access to care. In the public ICU, it was observed that it was greater than 6 hours after onset due to their health seeking behavior, while in the private ICU, it was less than 4 hours after symptoms of onset. And the results revealed that there were 40% survival rates in the public with 76% in the private, and the mortality 60% in public and 24% in the private, revealing that earlier presentations will result in better outcome. This is the table showing the public, number of patients 60, onset of presentation after onset of symptoms, greater than 6 hours for public, with a survival rate of 40% and a mortality of 60%. While in the private, out of 31 patients, less than 4% presented after onset of symptoms. And the survival rate was 76%, which is better in the private, and 24% mortality rate. Conclusion, private ICU showed substantial better outcomes which was signified with a lower mortality rate and higher better survival, strengthening emergency stroke pathways, improving public awareness because of the poor health-seeking behaviors in Nigerians or people in lower and middle-income countries, will enable and increase their presentation after onset, and enhancing critical care services in public hospitals may contribute to reducing stroke-related mortality in Nigeria. Thank you.
Thank you so much for this presentation. And we'll, without wasting our time, we'll listen to the third presentation from the same presenter.
Call out the name.
Saving lives against the odds through critical care success in a resource-constrained environment.
This presentation, right? When you say first case.
Saving lives
Yes, sir.
against the odds through critical care success in a resource-constrained environment.
So this is a case presentation I'll be doing on behalf of others. A background: persistent coma in patients after diabetic ketoacidosis after correction of metabolic derangements warrants urgent evaluation for concomitant neurological pathology. The coexistence of acute ischemic stroke, seizures, and cerebral edema presents significant diagnostic and therapeutic challenges, particularly in low-resource settings. This is a presentation of 47-year-old no hypertensive diabetic woman with previous history of right hemispheric stroke with a sudden onset of consciousness, loss of consciousness, a random blood sugar of 30 millimole per liter, and a Glasgow Coma scale of 8/15. She subsequently developed generalized tonic-clonic seizures, and a CT scan revealed chronic right hemispheric infarcts without acute hemorrhage. Despite aggressive fluid resuscitation, insulin therapy, and intensive care management, she remained comatose and presented with persistent metabolic acidosis, and she developed anisocoria. Repeat neuroimaging revealed a large left middle cerebral artery territorial infarction with significant mass effects and midline shift suggestive of malignant cerebral edema. Persistent depressed consciousness raised concerns for non-convulsive status epilepticus, recurrent stroke, and involving cerebral herniation. She had mechanical ventilation, and neurocritical care support were instituted, while arrangements for transfer to a specialized neurocritical care center were made. In conclusion, this case highlights a complex interplay between diabetic ketoacidosis, acute ischemic stroke, seizures, cerebral edema, persistent coma despite apparent metabolic improvement should provide prompt urgent neurological assessment, repeat neuroimaging, considerations of continuous electroencephalographic monitoring, early transfer to a dedicated neurocritical care facility may improve neurological outcomes in resource-constrained environments. Thank you.
Thank you, Dr. Gogo.
So just give it on the.
We are going to call on
Dr.
Dr.
Three.
She has done the three.
Present the level of grading and outcome in patients admitted to intensive care unit. Also a single center retrospective observational study.
Yeah, let me when I project it.
Dr. Adeya.
So press once back, press back, good, back to the beginning. So press once. Sorry, let me move the mic, the camera from him so that I don't know what. Okay. You can sit.
No, I just wanted to collect back as
yeah, I'll give you.
Good morning, all. Good morning.
Good morning, all. I'm standing on existing protocol. I'm Dr. Adeyanju. I'm the Senior Registrar at the University College Hospital Ibadan on the Department of Anesthesia and Critical Care. And this morning, I'll be presenting this paper, this study that we did, level of serum bilirubin and outcome in ICU patients. It's a single center retrospective observational study. The background on the objectives of this study, bilirubin has been proposed as a potential biomarker of disease, severity, and prognosis in critical care in critically ill patients. This association is actually driven by strong physiological links to hepatic dysfunction, systemic inflammation, and oxidative stress response. The key objectives of this study was to evaluate the relationship between serum bilirubin levels and clinical outcomes among patients admitted to the intensive care unit, and also to determine whether bilirubin acts as an independent predictor of ICU mortality and the overall length of ICU stay. So the study design, like I said earlier, is a retrospective observational study featuring 80 critically ill patients that were admitted to our ICU. Like I said, it's a single major center study. The parameters that were measured were analyzed patient demographic profiles, also clinical parameters, liver function indices, including bilirubin, and also the Glasgow Coma score. The statistical analysis that were used, we utilized the chi-square, the man-Whitney U-test, then the multivariate logistic regression for mortality, and multiple linear regression for ICU stay duration. Okay. So these are the characteristics of the patients that were admitted. The parameter category, age and gender, the mean age, the mean percentage. The mean age of about 57%, and 50% of these were actually males. Comorbidities, the highest was hypertension and diabetes, standing at 3.8% and 16.3% respectively. The leading diagnosis was cardiovascular accident, CVA, and also sepsis. And they both stand at 22.5% and 18.8% respectively. Then the primary outcomes, like previously stated, ICU mortality and survival to discharge. And this shows 57% actually died. That's about for six of the patients, and 42.5% survived. That's 34 patients in total. So for the outcomes of bilirubin, the comparative analysis, non-survivors presented with higher median total bilirubin levels compared to survivors. And so for the non-survivors, they had a higher bilirubin level. The non-survivors, yes, 0.8 with a range of 0.50 to 1.6 milligrams per DL. The survivors had a mean of 0.68 with a range of 0.43 to 1.44 milligrams per DL. So although elevated in non-survivors, the difference was not statistically significant, a p-value of 0.263. Predictor of ICU survival, the Glasgow Coma score, dominance, the multivariate binary logistic regression model identified Glasgow Coma score as the only consistent independent predictor of survival. Each 1 point increase in the baseline GCS score was associated with a 13.8% reduction in overall mortality. So the higher the GCS, the higher the chances of survival. Then predictors of stay, bilirubin to albumin and statistical analysis. So the total bilirubin showed no significant association with the duration of ICU stay. That's the value, the p-value as well. The multivariate models, total bilirubin to, that's the value, and the bilirubin to bilirubin ratio 2. So demonstrated a positive trend with mortality, but ultimately failed to reach statistical significance. Well, for this study, limitations we had was that insufficient data to sort out study population with the Apache scoring system. We noticed that just about 10% of all patients were actually scored with this. So the conclusions and takeaways from this: elevated but non-predictive serum bilirubin levels are higher among non-survivors, but were not independently associated with mortality or ICU stay after adjusting for the baseline co-founders. For neurological significance, baseline neurological status as assessed by the GCS score remains the strongest independent predictor of patient outcome. Further research needs to be done. The training positive situation of bilirubin and bilirubin to albumin ratio with mortality warrant larger scale prospective trials to settle their ultimate prognostic utility. Thank you all for listening.
Thank you for your presentation.
Let's give it on the table, everything, the mic. Yes, sir.
And the next presenter will be Dr. Omoni, going to present fluid management practices outcome in intensive care unit patients with sepsis and low salt setting. Omoni, you have the floor.
Good morning, sirs and ma'ams. This standing on existing protocol, I'll be taking this presentation this morning on field management practices and outcomes in intensive care unit patients with sepsis in low resource settings on behalf of these authors. So as a background, sepsis remains the primary driver of morbidity and mortality in ICU globally, and then it's what's more acute in our resource setting like Nigeria, where we have a lot of challenges with constraints with finding appropriate diagnostic markers, early care institution, and accessible sustainable healthcare financing. And one of the keystone of care for management of sepsis, especially in the resuscitative phase, is food administration, because it aids with its tissue perfusion and helps to stabilize hemodynamics. However, optimal feed strategy and risk of positive balance require localized evidence to maximize patient safety. So on this basis, we set out for this retrospective study, and the objective of the study was basically to evaluate the food administration pattern, clinical characteristics, and association with survival and length of stay.
Just press once.
This is a retrospective study, and 41 patients were recruited for this study. Patients were diagnosed of sepsis at point of admission in the course of care in ICU, and we assessed for demographics, admission and parameters, including meal score, daily food inputs and balance, and the need for advanced life support. Numeric analysis was done to ascertain relationship between these factors and outcome. Precisely, the outcome assessed was discharge status and then length of stay. So our findings were majorly males dominated. In terms of gender, male dominated proportion of population for this study, about 56%. Most of them were in the age category of less than 40 years, about 48.8%. And among them, in terms of diagnosis, most of them were post-operative patients admitted into the ICU, about 46.3%, and more of them had mean score less than 4, 51.2%, and more of them had a length of stay less than 7 days, 65.9%. Also, still on the demographics, we also noted that most of them needed invasive ventilation therapy, about 82.5% of them, and all the patients recruited had normal saline as part of their fluid therapy, while lesser of them had then dextro saline and other forms of fluid therapy. Most of them had a daily input of more than 3 liters per day. About 77.7% of them had an input of more than 3 liters per day, and 63.4% of them had a positive daily balance of more than 1 liter. And when we compared this admission characteristics of basically the need for vasopressor, need for invasive ventilation therapy, need for renal replacement therapy, need for blood and blood products, when we compared it to their discharge status, we observed that there was a significant relationship between the need for vasopressors and the need for invasive ventilation therapy. However, the other admission parameters didn't show any significant relationship. Also, when we compared this with the length of stay, there was also no significant association between these parameters. We also tried to find a relationship between the mean daily free status and admission status. They were not significant. As well as when we compared the relationship between the mean daily free status and the ICU outcome, vis-a-vis the discharge status and the length of stay, there was also no significant outcome to the relationship. So we found out again that the need for vasopressor and the need for invasive ventilation therapy were the major pointers towards determining whether the discharge status of the patient, and this underscores the fact that patient mortality is primarily driven by refractory shock and severe multi-organ dysfunction. And early identification of severe shock is quite important and addressing it is quite important before patients actually declines. But we also noted something which is quite important, the fact that over 78% of our patients actually had fed more than 3 liters per day. And the reason we ascribe to this is because in resource limited settings like ours, where we don't have access to more to active hemodynamic assessment and monitoring, usually we are constrained, and then we rely mostly on fluid and volume loading to optimize sepsis patients. And also to note that the lack of positive statistical outcome with excess free suggests the need for a stricter protocol when it comes to resuscitation of these patients. We have some limitations with this study. The fact that it's a retrospective study, it's a single center study, and then we had small sample size also was a limitation. And the fact that we could not categorize these patients in terms of their severity, like apathy scoring, also limited the inference from this study. Thank you.
Thank you, Dr. Moni. Presentation. I'm going to call on Dr. Kate Edinoko to come and do her presentation. Dr. Kate.
What is the name of your slide? PowerPoint, acute cerebral? Is it on acute cerebral?
Yes.
Okay.
Acute cerebral syndrome.
Good morning, professors, consultants, doctors, ladies and gentlemen here present. All protocols duly observed. I'll be presenting a case report on acute cerebral syndrome with transient blindness, sensorineural deafness, aphasia, and quadriparesis in a child with homozygous sickle cell disease despite normal imaging. Neurological complications are the leading causes of disabilities in people living with sickle cell disease. Stroke will occur in about 11% of this individual before adulthood. Some vaso-occlusive events will present with severe significant neurological deficit without abnormalities in the imaging. So what is unique about this child is the fact that this child presented with cortical blindness, sensorineural deafness, presented with aphasia, progressive quadriparesis. At the time, the child had seizures, the MRI was normal, CT scan done was also normal. This child had near normal neurological recovery. So the objective here is to note the manifestation, the unusual neurological manifestation of sickle cell disease that this child presented with, and also the challenges that we have in terms of early diagnosis because the imaging were not contributory, as well as the multidisciplinary care that was on board for this child, and to emphasize or demonstrate the benefit of urgent blood transfusion to recovery. So actually this is an 8-year-old boy, a no sickle cell disease patient who presented with fever, presented with bone pain, productive cough, inability to talk, sudden blindness, sudden deafness. He also had quadriparesis, progressive quadriparesis. And clinical presentation, this child was confused, okay? All these symptoms that we had was within 1 week, all the symptoms we talked about. He actually started with the bone pain, and then the fever, then the productive cough, and had an initial home treatment where a nurse came, set a line for him, gave him antibiotics, ceftriaxone, gave him diclofenac, gave him IV fluid. Of course, there was a sudden deterioration in neurologic deficit, which necessitated hospital admission. So the child presented confused. He was restless, blind, inability to speak, and the child unable to hear. And there was a quadriparesis, as well as at this time, there was now respiratory difficulties. On a clinical presentation, we saw, so the initial diagnosis that we saw were that of acute ischemic stroke, acute cerebral syndrome. We talked about cerebral malaria, meningoencephalitis. We also talked about posterior reversible encephalopathy syndrome. And we're also talking about
hemorrhagic intracranial bleed, as well as acute encephalopathy syndrome. So on investigation, this child was anemic. PCV was 20. Leukocyte counts were not too significant. Of course, the child was already on antibiotics, so they were 13,000. And the platelet counts were normal. The malaria was positive. Of course, brain CT not contributory. The only thing that was seen on MRI was sinusitis. And this child, also the MRI didn't show infarction, and it ruled that posterior reversible encephalopathy syndrome, because the difference between acute syndrome and posterior reversible encephalopathy syndrome is the fact that you will have MRI findings or CT scan findings. So these investigations ruled it out. So we now had a diagnosis. So the diagnosis were that of acute cerebral syndrome. Okay. So the diagnosis were that of acute cerebral syndrome, vaso-occlusive crisis, of course, anemia was there, malaria was there also, and probable acute chest syndrome, because this child had a bone pain. We also talked about following investigation, right humeral fracture and avascular necrosis of both shoulders. Of course, we will know that when you talk about vaso-occlusive crisis, so at this level, there's hypoperfusion of the bones that will lead to avascular necrosis. So the care, just quickly on the pathophysiology, when you talk about polymerization of hemoglobin S, this will result in red cell sickling. And when there's sickling of the red blood cells, they are unable to meander the microvasculature, resulting in obstruction of this microvasculature, resulting in cerebral hypoperfusion with neurological dysfunction. And there can be no significant MRI findings. So in ICU, the patient received oxygen therapy, well hydrated. We treated the malaria, we gave antibiotics, and we also did mild sedation. I'll lay some emphasis on mild sedation to be able to achieve Ramsey sedation score of between 3 and 4, although there were difficulty assessing that because the 3 is to talk about responding to command. But this was a child who was deaf, who was dumb, and all at that time. So, but we were trying to balance allaying fears and anxiety and sedating this child. So we did some NG2 feeding, and then we also brought physiotherapy on board, okay? Oh, 2 minutes, okay, good. So for exchange blood transfusion, this child had exchange blood transfusion 4 times, and the aim was to reduce hemoglobin S in the system, reduce sickling, improve oxygenation, so that the macrovasculature will not be obstructed. There will be reduced viscosity, and this will reverse the vaso-occlusion. So the event in the ICU, the child had 3 seizures, okay, which was abducted with midazolam. The child had the hypotension from the use of diazepam, and then we put some non-epinephrine to up the blood pressure. This child was seen also to be restless, on account of which we gave some midazolam infusion. So multidisciplinary care, like I said, the pediatrician was there, the hematologist, the ICU team, the physiotherapy. We also brought on board the orthopedic surgeon, even the anesthetic team. They reviewed this patient for possible surgery if patients get better. And this ophthalmologist saw too. The ENT surgeon looked at the ears, the eyes, and we're all tying down to vaso-occlusive occlusion, multisystemic affectation. So the beautiful thing why we talk here is the fact that neurologic recovery, this child recovered sight, speech, hearing, motor came back, recognition of relatives were optimal, only for residual slaughtering, which has long resolved because the child, she comes to us as at the time the child was sent home. And that blood transfusion, exchange blood transfusion helped because it reduced the sickling, improve cerebral oxygenation, restore cerebral oxygen perfusion, and therefore prevent further sickling and reduce the inflammatory cascade that resulted in all those neurologic deficits. Oh, time of discussion. But I think just one slide to go. Can I go? Sorry.
Literature.
Okay, a few. So from the end, okay, in conclusion, acute cerebral syndrome may present with profound neurologic dysfunction despite normal neuroimaging. And early recognition, multidisciplinary team, prompt exchange blood transfusion can achieve remarkable neurologic recovery. Thank you.
Thank you, Dr. Gates. Enjoy your presentation. Now we are going to listen virtually to Dr. Ijoma Emedike Anwa. He has two papers. Ifeoma Emedike Anwa. Ifeoma Emedike Anwa. He has two presentations to do. One is course of intensive care management of hypertensive and diabetic patients with kidney failure, acute respiratory distress syndrome, hemorrhagic stroke, a case report from a resource-rich setting.
Good morning. Good morning.
Morning.
I am presenting the cost of intensive care in management of hypertensive diabetic patient with acute kidney injury, acute respiratory distress syndrome, and hemorrhagic stroke, a case report. I'm co-presenting this with, my name is Ifeoma Emedike Awa. I'm co-presenting this with Paul Ofebulam, Department of Anesthesia, Memphis Hospital, Enugu State. This is my outline: introduction, case presentation, discussion, conclusion, references. So this is an ICU. Hypertension is the leading risk factor for spontaneous intracerebral hemorrhage, while diabetes mellitus contributes to poor neurological outcome and increased susceptibility to infection. This could lead to acute respiratory distress syndrome and acute injury with prolonged stay in ICU. Prolonged mechanical ventilation, renal replacement therapy, and comprehensive organ support will increase health costs, particularly in resource-limited settings where out-of-pocket payment remains a concern. This case is a 48-year-old businessman that was hypertensive for a long time, uncontrolled diabetes with hemorrhagic stroke, with acute kidney injury, severe acute respiratory distress syndrome, with 3 days loss of consciousness. On admission, he came in with a glycoscopy scale of 5, blood pressure of 228, 130 millimeter mercury, 108 beats per minute, respiratory rate of 30 breaths per minute, and oxygen saturation was a 6% on room air, and he had SOFA score of 10. The CT scan showed demonstrated intracerebral hemorrhage. And because of this, he was admitted into ICU. He was intubated and attached to mechanical ventilation. The daily investigations were full blood count, clotting profile, urine MCS, serum electrolytes, urea, and creatinine. And Doppler ultrasound scan was done on him. Inflammatory markers were done like procalcitonin, C-reactive protein, bronchial aspirate MCS, arterial blood gas was done, central line cannulation was done, and arterial line cannulation antibiotics were administered. So the cost analysis. This Memphis Hospital is a highly resourced center, highly equipped center, neurological center. This patient stayed for 19 days in ICU, and he made a deposit of 12 million, which is approximately $9,000. And in the cost analysis, we divided into two: the direct cost and the indirect cost. The direct cost, the mechanical ventilation per day, all of them are incorporated inside the 12 million. Mechanical ventilation per day is 138,000 naira. The cardiopulmonary resuscitation is 165,000 naira per day. The deep venous thrombosis pump per day is 83,000 naira. Dialysis is 50,000 naira. The MRI scan of the brain, 154,000 naira. The CT angiography, 165,000 naira. The CT chest scan, 31,000 naira. The ICU care per day is 220,000 naira. The non-surgery ICU admission, 165,000 naira. The total cholesterol, 50,000 naira. So the indirect costs, the taking care of the caregivers, taking care of them, the long-term rehabilitation, the transportation from ICU to the dialysis center, from the dialysis center back to ICU. All of them were incorporated inside the indirect cost. So my discussion demonstrates the financial implication of managing critically ill patients with multiple organ failure. Intracerebral hemorrhage alone is associated with high mortality and resource utilization and treatment cost, which will be high. Healthcare financing relies on out-of-pocket payment in this country, and it exposes families to catastrophic health expenditure. So we need a robust health insurance scheme system, implementing evidence-based ICU care bundles, preventing nosocomial infections, and optimizing early multidisciplinary approach. All these things will buffer the cost. My conclusion, good governance and leadership will lay a good foundation for quality and universal health insurance policy that will boost intensive care units in the country. Thank you. These are my references. Thank you.
Thank you so much, Dr. Ifoma. You actually demonstrated to us that this is a rich resource setting. Thank you. Then we are going to listen to your second presentation. Percutaneous tracheostomy as a facilitator of weaning patients, anticipated prolonged mechanical ventilation, also a case report.
Yeah. Thank you. Good morning. I'm presenting percutaneous tracheostomy as a facilitator of weaning for anticipated prolonged mechanical ventilation, a case report. My name is Dr. Ifoma Emedike Awa. I'm co-presenting this with Dr. Paul Ofebunam, Department of Anesthesia, Memphis Hospital, Enugu State. So this is my outline, introduction, principle, case presentation, discussion, and conclusion. Percutaneous tracheostomy, PEC-TRAC, is a bedside procedure. It's minimally invasive, where you insert tracheostomy tube inside the trachea. So this is a diagram of the trachea, the skeleton of the trachea. Where you normally insert the tracheostomy tube is between the first, second, and the third tracheal rings. So you can see the diagram there. This is where they put you can do the cricothyroidotomy. This is where you can do the surgical tracheostomy. So this procedure has advantages over the surgical. The main tracheostomy is cheap, is cost effective, is comfortable. It has good cosmetic outcome. It reduces the need for sedation. It improves airway toileting, and it reduces the incidence of ventilation-associated pneumonia. It applies the principle of modified Seldinger technique, where you can use this the dilator, the Saglia Blue Rhino G2. So the modified Seldinger technique is where you use several dilatators you insert it over the guide wire for you to insert the tracheostomy tube. So this patient, this is a 33-year-old businessman that came with 3 days loss of consciousness with severe head injury, multiple depressed skull fracture, and the CT scan demonstrated cerebral edema. So this procedure, the decision to take this procedure was on the 5th day of admission into ICU. We did not wait for the normal 7 days duration. And investigations carried out where the hemoglobin, before the procedure, the hemoglobin was 9 gram per DL, the red blood cell volume was 4.21 cubic centimeter, the chest X-ray, chest CT scan, serum electrolyte, procalcitonin, C-reactive protein, all of them were within normal range. So the patient fasted before the procedure. And the day of the procedure, standard monitors were placed on him. Then he came in, we started with a Glasgow Coma scale of 7. The baseline parameters were, the invasive blood pressure was 138.77 millimeter mercury. Invasive blood pressure was 160.70 millimeter mercury. The pulse rate was 105 beats per minute. The mean arterial blood pressure was 85. Respiratory rate was 18. End-tidal carbon dioxide was 39. Oxygen saturation of 97%. The ventilatory parameters before the procedure, the tidal volume was 500 mils. The positive end expiratory pressure was 5 centimeter water. The inspiratory expiratory was 1 to 2. The expiratory tidal volume was 419 mils. The inspiratory pressure was 9 centimeter water, and the pressure was on spontaneous mode. The vent was on spontaneous mode when we started this, before we started this. So before the procedure, we extended the neck, and a roll was kept under the scapula of the patient. The tube was adjusted from 23 centimeter length to 22, and the patient was sedated with 50 milligram of propofol and 10 microgram of fentanyl. So the landmark, we maintained that midline landmark. The landmark was identified between the second and the third tracheal ring. The puncture site was infiltrated with lidocaine and adrenaline, and neuromuscular blockade was achieved with 4 milligram of pancuronium to relax this patient. So on the puncture, after the needle, 16 G cannula was used to puncture the site, and the guide wire was inserted through the needle, and the dilatators were inserted over the guide wire. After a dilatation, the guide wire was after inserting the tracheostomy tube, the guide wire was then pulled out, and the patient was connected to the ventilator. And the correct placement was confirmed with bilateral chest expansion. Auscultation was good. There was good air entry. The ventilatory parameters were pulse rate of 101 beats per minute. Oxygen saturation increased to 100%. The invasive blood pressure came down to 155.75. The non-invasive 154.77. The mean arterial pressure was 100. The end-tidal carbon dioxide was 41. The peak pressure was 16. The expected tidal volume was 502 mils. The procedure lasted for 20 minutes, and there was minimal blood loss. The chest X-ray showed no pneumothorax, and within 24 hours, the patient was stable. The Glasgow Coma scale was still 7/15. The next day, this patient was disconnected from the ventilator and was transferred to the high dependency unit. My discussion, peg track is a preferred method of airway access in anticipated prolonged mechanical ventilation. And one advantage this procedure has is that it prevents transportation of critically ill patients from ICU to scan room and for scan room back, thereby making the patient unstable. My conclusion, timely intervention can shorten ICU stay, leading to a better outcome in ICU. Thank you. These are my references. Thank you.
Thank you so much for your presentations. You can still wait for questions from audience. Thank you. So at this junction, we are going to collect questions from audience, both physically and virtually. Those of us that are virtually should drop their questions in the chat box, and it will be addressed. And then physical participants should raise your hand and ask your question and also direct it to the presenter. Thank you. We have just less than 10 minutes to do this activity. Thank you. The first question, sir. You can ask your question, sir.
10:30. So I will look forward to
Dr. Paul.
He's already online.
How can you present such a paper and there's no picture showing anything? You telling us about percutaneous tracheostomy, apart from the percutaneous tracheostomy that you showed, nothing at all about the procedure. It's acceptable. Thank you.
I think as a society, I don't know how many of us can hardly do percutaneous tracheostomy. I don't know how to do it. Dr. Paul knows how to do it very well. So I think that as no, because we're a prodigy of sport, so I think he's before he escapes, everybody's on the move now. I think we should beg Paul during our ESCO year, so that depending on like agreement at the next AGM, you will demonstrate it live. The house, I'm begging this guy to demonstrate it live so that we will learn it, because I plan to go to Enugu. Nigerian roads are terrible. Anywhere we can find ourselves now. So let us learn this thing well. So question for anybody who is presenting and you're listing GCS. GCS, always give us the components of the GCS. It's easier for us than just saying just GCS. For the Ibadan FA, Ibadan, money. So your study is very fantastic. I was just thinking, were you looking at positive fluid balance and mortality, morbidity, or length of stay, or outcome? Negative fluid balance. If you just said fluid, Prof, maybe that Prof went. But I know that positive fluid balance in ICUs mostly look at the effect of positive fluid. Instead, there's a correlation between positive fluid balance and mortality, or increased length of stay. So I don't know whether that was what you were looking at, or you're looking at just descriptive analysis of fluid use in the ICU. I don't know. I'm just trying to think out loud. Then the other one is a fantastic one. No, the other one is a but now go socioeconomic factors influencing is fine. If we correlate that with what Ifoma presented, that tells us, give us an overview of what happens in public hospitals and what happens in
I think I'm talking about it.
and private hospitals as well. And even though you don't tell us what percentage of Nigerians actually patronize private hospitals and what is their economic, status in terms of, is it really the rich? You can also give us an idea of how to push for what we discuss at the panel discussion. Is it only those who are rich that should live, and those who are poor that should die? So if you do your study and look at the population dynamics, it helps us give us an idea, because as the Rotimi committee, that will give us a communique. I hope you are looking at these presentations, and then Prof. Rotimi shaking his head, though, is behind you.
PP, I'm a bit, I'm sorry for not allowing, but not insisting to post the videos. But I'm going to record a video, because this procedure is done routinely in the ICU. So we've done, it's our standard procedure. So we've done more than 40, more than 50 of it in the last 2-3 years. Even the ones we are doing at UNTH, because I learned it from the Americans who came in to train us in fundamentals for critical care. So I equally taught the residents, including Dr. Friday, equally does it at UNTH too. So the procedure is not difficult, and it's something that can be learned in one workshop. Even the one we plan for Wiri. It was unfortunate that workshop was not really held, but we did a very elaborate plan to even get live animals neck, which would have used. So, but in the course of this ESCO, we'll make every effort to get that workshop done, so that as many of our members will be able to learn how to do it. Then concerning, my question goes to the people, the GoGo group that presented acute stroke outcome in public and private ICU. I was waiting to hear the NIS score of the patients, the severity and the disability score on the patient on admission. So that when you are comparing the two places, you're able to see how badly the disability score of the patient. Then you didn't state the type of stroke, whether it's hemorrhagic or ischemic stroke, comparing the two locations. Then for the money, it's like this, the study is a retrospective study. So, but although you rightly said that you would have used Apache in determining the severity of illness of the patient. And then I equally noticed that you didn't use the SOFA score too, because this is sepsis. So rather you use the modified early warning score system. So maybe because it's a retrospective study. So probably in the future, those ICUs will make sure they put in place such standard scoring systems so that they can compare your study with others. Thank you.
And so, from the plans online.
Yes, Mike.
Yeah, just the team from Menu could have presented the last presentation on hair injury, tracheostomy. Yeah, it's an interesting device used in the ICU for ventilation, and the earlier is to be restarted, and you can recover. The patient can recover faster and go back to the ward. But my question is, you had a coma score of 7/15, and the patient was extubated and discharged. How? That's just what I wanted to clarify. How? 7/15. That is still critical stage of the case. And the patient was extubated. And I don't know, discharged out of the ICU. Have you misunderstanding?
We have only one person virtually that wants to ask his question, Dr. Daramola. Dr. Daramola, unmute yourself and ask your question.
Hello, good morning. Good morning, sirs and mass. Can I be heard?
Yes, yes.
All right. Thank you very much to the presenters. My question goes to the last presenter concerning the percutaneous tracheostomy. It was a nice one. I would join Prof in saying that pictures of the actual thing, because you just showed us normal anatomy of the trachea, of the larynx and all of that. The procedure itself and the tracheostomy, percutaneous tracheostomy in situ would have been nice for us to view, you know, of course, with the patient's face blocked. But my question is, you kept saying that this procedure is good for patients that are going to stay long in the ICU. Yet your procedure was done on a patient that went to the HDU the following day. So how are we sure that, okay, this is actually good for patients that are going to stay for long in ICU? So because your patient didn't stay for long in ICU, so maybe you would have probably chosen another case of a patient that stayed longer in ICU. Your patient went to the HDU the following day. So I couldn't correlate the importance of the percutaneous tracheostomy in this patient. Thank you very much.
Dr. Daramola, I think Dr. Ifeoma will drop it in the chat box. We have our guest speaker waiting for us online. So without wasting much time, I think we have done justice to the questions here. So with this view, we are going to allow the next presenter, the next speaker to present to us. At the end, of his presentation, then the assessors will gather here again, and our assessors will tell us the best abstract presenter consultant and the best abstract presenter resident. Thank you all for listening. Thank you all.
Hello, good morning.
We will read your citation first before you make the presentation, sir. Is that okay?
Okay.
Just give us 2 minutes for our Vice President, Dr. Irene Akindeno, to read your citation. Thank you.
Can I share my screen right now?
Yes, you can go
Okay,
ahead.
you can share the screen.
Okay, okay.
Oh, he's already online. Slideshow, we will open it up.
If you can make his face.
Yes. Slideshow. Yes, good. Then you can.
Good morning, everyone. Welcome to our first lecture for today, to be given by Professor Louis Blanc. He's an internationally acclaimed intensivist, biomedical innovator, and researcher based in Barcelona, Spain. He serves as senior consultant in critical care medicine in Parc Taulí University Hospital. He's director of research and innovation at the Corporació Sanitària Parc Taulí, and associate professor at the University of Barcelona. He also coordinates ITMAS, which is Spain's national healthcare innovation platform, under the Carlos Ill Health Institute. Professor Blanc is globally recognized for pioneering work in mechanical ventilation, respiratory physiology, patient ventilator interaction, and the application of AI in critical care medicine. His research has significantly advanced the understanding of respiratory failure and the optimization of ventilatory support in critically ill patients. An accomplished scientist, he has authored more than 350 scientific publications and accumulated over 12,000 citations. His work has received international recognition for bridging clinical medicine, biomedical engineering, and digital health technologies. He's also an inventor, holding patents related to monitoring systems that improve patient safety and ventilator management. Beyond academia, Professor Blanc has held several influential leadership positions, including president of the Spanish Society of Intensive Care Medicine and president of the Catalan Critical Care Society. In 2025, he was elected corresponding member of the Royal Academy of Medicine of Catalonia in recognition of his outstanding contributions to medical science and innovation. His career exemplifies the integration of clinical excellence, technological innovation, and translational research, making him one of Europe's most respected leaders in intensive care medicine. Please join me to welcome Professor Louis Blanc, who will be talking on applied physiology and mechanical ventilation. Thank you. You're welcome.
Good morning. Thank you very much for this kind invitation to be here. I would like to thank Dr. Otoguala and the rest of the members, sirs and ladies of the organizing committee, for allowing me to be here. Can you see the presentation?
Yes.
Yes? Okay. So the topic today will be applied physiology for mechanical ventilation, though this is a broad topic, so I will make several considerations about that. First of all, my conflict of interest, as it was described previously, I'm an inventor of this Parc Taulí owned patent. I am founder also of a company which is doing research on real-world data from physiologic signals in the ICU, and I received grants for research for my group. So I would like to start this talk saying that what are the objectives of mechanical ventilation, because this is the most important. We know that mechanical ventilation is not a treatment. Mechanical ventilation is just to support patients when they are, treatments are acting, whereas the diseases are ameliorating in these critically ill patients. So we need to support the respiratory system. So mechanical ventilation should be safety, should be efficacy in oxygenation, ventilation, and decrease, in that case, work of breathing. And more important, and perhaps the most is, it should act in comfort with the patient and in synchrony with the patient. So I would like to stress that for mechanical ventilation, we need to surveillance all the time at the bedside waveforms of flow, airflow, and pressure. Mechanical ventilation can be easily, understood going to the mathematics. The pressure, to enter flow, air in a system depends on the resistance and the compliance of the system. Okay, the resistance in that case is given by all the airways, and compliance is given for the physical state of the alveoli. If we go further, when there is an increase in that case in resistance, then it needs more pressure to get in. When there is in that case a decrease in the compliance, it decreases. It increases elastance. Distensibility decreases, and then we pay also a price in the pressure to get air into the alveoli. The question of motion, which is what's necessary to enter air in a system, depends on that case in the product of flow and resistance, in the volume as a function of, in that case, of compliance, and then K, which is a constant, which is the pressure that at end expiration is within the alveoli. Very simple. Mechanical ventilation is two issues: volume, in that case, or in that case, flow. The two main systems of mechanical ventilations are volume control square or decelerated flow, where we set flow or volume, and then the dependent variable is pressure. And at the bedside, we always see pressure that give us information about the peak pressure and the plateau, where taking these two, plateau, the peak pressure and the plateau, we get the resistance of the system, and we do an occlusion at zero flow. With the plateau, we have the plateau pressure, which is critical to do not, stress, in that case, the lung. And as I will discuss later on, we get important information with the plateau minus P about the driving pressure. For pressure control, we set pressure. At whatever pressure, according to the mechanics, it will enter, determinate volume in the lungs. In that case, flow is completely decelerating exponentially up to a point that sometimes reaches to zero, where the pressure at the airway equals alveolar pressure. We also can do an occlusion here and get, in that case, also a plateau pressure. So these two systems, it's what regulates, in that case, mechanical ventilation. So the physiologic, markers during mechanical ventilation that now I will discuss is the ventilatory efficiency, the driving pressure, recruitment and oxygenation, circulatory effects, inspiratory effort and dyspnea, and then patient-ventilator interaction, which is fundamental, and mechanical ventilation and long-term outcomes, where here, today is more and more important, the relationship between the brain and the lung during mechanical ventilation. If we have a lung model that represents, in these three alveoli, essentially, and summarizing, we can have an alveoli which represents a pure shunt, in that case, compartment. So there is no air getting to the alveolar, no air participating in the gas exchange. So, in that case, there is no improvement in oxygenation. And then on the other side, there is a pure dead space compartment when there is no perfusion. In that situation, there is no, in that case, exchange in PaCO2, in CO2, and this is the pure shunt. In the RADS and during the mechanical ventilation coexist all these three types in that case of alveoli, normal or quasi-normal, I mean data space areas and shunt areas. And then during mechanical ventilation, we need to recruit the lungs, improve shunt, in that case, try to do not, I mean, over-distend more, that it will increase, in that case, data space and preserve, in that case, the healthy units. I will start with data space. We know that data space is associated with mortality in RADS and in patients in mechanical ventilation, not only RADS. This is another study saying that as data space increases, the mortality augments in patients with RADS. So I would like to stress that in patients under mechanical ventilation, mostly with severe hypoxemic failure RADS, it coexists shunt areas with data space areas. If data space increase, mortality in that case increase. So at the bedside, we have some kind of non-invasive techniques for detecting data space. And I would like to stress one of these, which is the ventilatory ratio, which is an index of lung efficiency, which reflects the relationship between measured and predicted, in that case, PaCO2. This is easy to do at the bedside, and taking simply, the minute ventilation and the PaCO2 measure, we can have this ventilatory ratio where if it increases, I mean, it increases the risk of mortality, even when this is adjusted for oxygenation and different PIP at different Apache scores. What it has been shown that data space and ventilatory ratio correlates very nicely. I mean, oxygenation do not correlate in that case with ventilatory ratio, so it's more accurate at the bedside, data space and ventilatory ratio, and this in the two big studies published in the literature, high ventilatory ratio, I mean, it goes with the probability continuing mechanical ventilation and also increases mortality. So the physiology at the bedside, taking into account what data space tells us, it's very important. Let's talk a little bit about the driving pressure. I mean, the driving pressure, which is the difference between the plateau and the PIP, completely in static conditions and in patients who are not making inspiratory efforts, is an index very, very useful in that case at the bedside. In fact, in this publication of Marcelo Amato and co-workers in more than, 3,500 patients show us that as driving pressure increases, mortality also increases. And there is a range of the driving pressures around 10, 12, 15 that, we can play with even at different tidal volumes, and mortality in that case do not increase. So at the bedside now we have another index, which is at whatever tidal volume, of course, using lung protective ventilation, if we measure in that case driving pressure, it should be below 15 as a, let's say, magic number, or as below as possible, providing that there is efficiency in that case of ventilation and an appropriate oxygenation. Very easy to measure at the bedside. So reductions in tidal volume or increases in PIP, driven and random group treatment assignment were beneficial only if were associated of decreases in the driving pressure. This tells us that if we are modifying tidal volume or increasing PIP and driving pressure increases, be careful, because it will not be associated. There is not a good physiological outcome, and maybe mortality will increase. This is a systematic review saying that in a lot of studies, a lot of patients saying that high driving pressure in that case is associated with increased mortality in that case as a raw data and in a sensitivity analysis. So driving pressure at the bedside is very important. But look at that. This is a paper that I contribute because the patients not always are passive under mechanical ventilation. And here we have an example of airflow, airway pressure, and tidal volume. This is in volume control. So we said volume, and the dependent variable in that case is pressure. Look at here. Here we have a reverse triggering. So, here there is an inspiration by the patient. Okay, so we cannot in that case, calculate, in that case, the plateau pressure. This is a completely passive breath. So we have a plateau and a PEEP. So the driving pressure here is correct. This here is a double triggering or a double cycling. As you will see, even here, the plateau pressure seems to be reliable, but is affected for the previously breath stacking, the volume stack that does not contribute in that case to expiration. So this is not a good breath. So in this, let's say 8 breaths, only in 2, we can really measure the driving pressure. So we need to choose the appropriate breath in order to have, in that case, the right driving pressure that will help us to titrate tidal volume and peak. Let's talk about recruitment. Recruitment is the nicest thing in the severely injured lungs. This is a pressure volume curve, a static pressure volume curve in a patient with RADS, human RADS. When there is no PEEP, the lung is collapsed. As soon as we are increasing, in that case, PEEP, the lung opens, mostly opens totally. Also, there is some over-distension here, but there is maximal recruitment. And the way down, the lung starts to collapse. And interestingly, for the same pressure, there is more air remaining to the way down of the PEEP curve. That's why many clinicians set PEEP with a small previous recruitment maneuver and then to set PEEP in the way down. So recruitment is important. Recruitment, there are 2 types of recruitment. The patients that completely recruits, this is a patient with a RADS that if we apply a PEEP, in that case, higher pressures, there is an inflection point, so recruitment starts here. So we increase pressure up to this point, and the majority of the lung measured on the CT scan, there is recruitment and almost no over-distension. Based on that, there is publications by Marcela Maten saying that if we do aggressive recruitment maneuver, which is a plateau pressure in that case of 60 and the current PEEP of 25, if the lung of the patients can be recruited completely, the areas of collapsed tissue decrease absolutely as near a normal lung, and oxygenation increases up to more than 400 millimeters mercury. And this is the CT scan. This is the magical little bit of this patient. However, at the bedside, we cannot distinguish the patients that I was talking of this patient that I'm going to present here. This patient has also a RADS. It fulfills any of the 4 or 5 definitions that we have of a RADS. But when we increase PEEP up to 15, there is no recruitment and over-distension, almost no recruitment, and over-distension in that case increases. But at the bedside, we cannot distinguish this. So this constitutes a big problem. So this is the first, aspect that I would like to mention to you. Physiology is caution at the bedside to sit down there and to try different PEEP levels. And now I'll show you some techniques to appropriately recruit or not the patient. This is a paper that I did together with John Marini in the past that regarding the etiology of the patient under mechanical ventilation, there is recruitment or not, or the lung is more recruitable or less recruitable. So this is a lavage model. You can see here that we use, this is an experimental model, we use high tidal volume, high PEEP, and look at that. Recruitment, the lung remains recruited during the recruitment maneuver. However, in this patient with pneumonia, this experimental animal with pneumonia, which is more unstable, even if we recruit the animal, in just 10 to 15 minutes, the PaO2 goes to basal and do not stay high, because it's very difficult, to sustain this type of recruitment. And this usually happens at the bedside. This is another paper where we did a recruitment maneuver and then we set the PEEP. In that case, tidal lung protective ventilation. And then we used PEEP 14. Then we did a recruitment maneuver, which is in that case, it's here at the 0 point. And then you can see that the increment in oxygenation is associated with an increment in compliance, these black circles. The increment in oxygenation, in that case, is associated with a decrease in that case in the chant, but what is seen here is that several patients do not respond to the recruitment maneuver when they are appropriately ventilated. And this is particularly important because when in more than 1,000 patients, the randomized trial was done, it was shown that lung recruitment with high PEEP and high distending pressures was associated, in that case, with an increase in mortality. So, what we should do? We should apply gentle PEEP in patients under mechanical ventilation and base it in two concepts. This is the results of the RECRUIT study in the upper part. The RECRUIT study was done using electrical impedance tomography to assess the point of maximal, in that case, maximal, let's say, or appropriate recruitment, as you will see here, and appropriate also overdistension and collapse. And this is done at PEEP levels of 12, 13, and 14. When they assess ventilation distribution in the anterior and posterior part, in that case of the lung measured with electrical impedance tomography in this central point, they found using this level of PEEP, 14, 15, 16, was the most appropriate. So, I mean, they match collapse and overdistension to optimal levels and also the ventilation distribution. If you do not have, in that case, electrical impedance tomography, there are other techniques to do that. In the systematic review and meta-analysis found that the electrical impedance tomography deriving PEEP setting strategy are associated with potential benefits in respiratory outcomes and make totally sense because what we are doing is equilibrating overdistension and collapse in this patient. Recently, a maneuver was described, to calculate recruitment. This is, a tracing of flow, pressure, and esophageal pressure, and this is the level of PEEP. These authors decrease suddenly PEEP, in that case, 10 centimeters water, usually from 15 to 5, and measure the expired volume. In other words, if the expired volume is so high, it means that in these 10 centimeters water, really they were recruiting the lung. If this expired volume is very low, it means that these 10 centimeters of water do not produce any increase in recruitment. This is the physiological principle. And here you can see that. For example, when there is recruited volume, they decrease. This is tidal volume, which, it's the expired tidal volume, and all this is the recruited volume. If this is too high, as a function of the decrease in the 10 centimeters of water, this means that there is recruitment. This can be seen here, measured at the compliance of this volume, which is as a function of the delta volume of, in that case, the delta pressure. In that case, the compliance here is 14, which means that, there is no recruited volume, and in that case, the compliance for the tissue of this exhale volume is 60, which means it is recruitment. If I go to that graph, this is very easily to do at the bedside. You measure the expired volume, you subtract the tidal volume, and then you calculate the compliance of this volume. And easily you will assess quite nicely if the PEEP you are applying is recruiting or is only maximally or is only majoritarily doing overdistension. Concepts of physiology. This is the normal lung, as you will see here. It's a very nice geometric structure. So the concepts that, when the lungs collapse a little bit and do atelectasis, when the lungs overdistend, or when there is maximum insist or whatever overdistension, these junctions between alveoli suffer pressures up to 100 centimeters of water. And this cycling, open and collapse, all this can cause stress, which is increasing pressure, tension, a strain, which is deformation, a stretch, which is, when we stretch fibers, and shear and shear. And this is nicely seen here. This is an alveoli. This is an alveoli. And this is the capillary pressure, and this is the interstitium, okay? So, increase in capillary pressure, increase in lung function, can affect the stress, strain, and also it can affect a stretch and a stretch of the capillary wall. I'm saying this because on top of what happened in the alveoli, what's going on in the capillaries, also it's very important. Imagine that we have overdistension, increasing capillary pressure, then the shear forces will cause, rupture of these membranes. If this accounts with the strong inspiratory efforts, as I will talk later on, this will be worse. So these are intrathoracic effects in PEEP beyond oxygenation that we must take into account. Effects on pulmonary vascular resistance that I will discuss now. It decreases venous return, so we need to really pay attention in that case to cardiac output. It counteracts chest wall. That's very, very important because in patients with low chest wall compliance, we need, superior levels of PEEP. It might overdistend areas in the non-dependent regions, and this can increase that space. It counteracts airway closure, very important because sometimes we need only 8, 9, or 10 of PEEP, to counteract airway closure. It decreases transmural systolic pressure, and that's very, very important. This decrease in left ventricle afterload when we are intubated patients in cardiac edema, because it helps cardiac function and also recruits dependent regions. This is an example of what happened in pulmonary vascular resistance. This is the pulmonary vascular resistance in 3 different circumstances. When the lung volume is normal at FRC, then the vessels are normal, and this is pulmonary vascular resistance, I would say here, they are reduced or they are normal. However, when there is atelectasis due to low PEEP or low lung volumes, there is an increase in pulmonary vascular resistance by this atelectasis and collapse of the alveolar capillary units, and there is hypoxic vasoconstriction. And this is deleterious. And then, on top of that, in this atelectasis, it might be tidal recruitment, let's say, cycling, opening and closing of these alveoli. So, a number of mechanisms in the lung, and also if pulmonary vascular resistance is increased, it will affect right ventricle. On the contrary, when there is, due to high PEEP, in that case overdistension, there is a compression of the pulmonary vessels, increases in pulmonary vascular resistance, and also it might increase the cor pulmonale. And this is very important, and I took only one slide on the effect of the injury in the right ventricle in patients in mechanical ventilation, and in particular in acute respiratory distress syndrome, saying that, if there is, in that case, a failure of the right ventricle, there is an increase, in that case, in mortality. Again, we need to pay really, really attention on the cardiopulmonary interactions during mechanical ventilation. Venous return, pulmonary vascular resistance, and also, in the left ventricle. So, during mechanical ventilation, now mostly we were talking about mechanical ventilation in passive conditions, but the patients breathe. And the patients breathe according to what the brain, in concrete, the respiratory drive, which is here, in the bulbar protuberancy, it's indicating. The respiratory center is heavily influenced by chemical input, by physical input. Also, it's influenced by at the cortical levels, and is influenced also of the afferents of the muscles. These conditions, in that case, the effect of drive. If we look at here, what influences in let's see if I can remove this. Wait a minute. Okay. The causes of increase in in the respiratory drive during mechanical ventilation, I mean causes that affect the respiratory center, we have all this anxiety, pain, discomfort, I mean inflammation for whatever disease, some neurotropism like in SARS and other viruses, biochemical input, which is acidosis, data space, SHAN, and mechanical input of the different receptors in the lung and muscles, afferents that go to the respiratory center. Having said that, the consequences of increasing the respiratory drive, it's increase in inspiratory effort. If the inspiratory effort is so high, I mean there is a decrease in the alveolar pressure, an increase in tidal volume, there is pendeluth, which is movement of air to, to different regions of where it should go, an increase in esophageal swings, an increase in the respiratory rate. All this increases the transpulmonary and transvascular pressures, and this may cause alveolar damage, microthrombosis, capillary leak, lung edema, impairs gas exchange and mechanics, increases. I mean, injury to the lung, what has been called patient self-inflicted lung injury, and dyspnea. And this is very important. If we want to a little bit summarize this, the patient is breathing spontaneously, is the transition, sedation is decreasing, the patient starts to breathe, here's a tracing in pressure support. As you will see here, this is pressure, have in that case an inspiratory effort. So there is a combination, the patient is in pressure support, but still here, the patient is having a huge inspiratory effort until the patient relaxes. This is called the iceberg mechanism. We have airway, but all this is the pressure swing, the negative pressure swing, intrathoracic swing that we can measure at the esophageal pressure. What we have is the total pressure that can cause a stress and a strain. How we can measure this at the bedside? Simply as a comment, what we have is that we can measure, in that case, the pressure muscle index, when, in that case, pressure stops, and then there is a relaxation. It increases to the level of the intrathoracic, in that case, pressure, because the effect of the muscle does not exist. So this is the whole delta pressure that we must take into account. This may cause injury. And also, during expiration, we can do an occlusion pressure, which is a surrogate of the swing of the negative intrathoracic pressure. So at the bedside, do we have elements to extrapolate to physiology and to better ventilate our patient? There are several papers. I took this paper of Parrilla when continuously monitoring inspiratory effort when the patient starts, in that case, having, respiratory effort, it shows that the ones that presented high in red during more time, longitudinally during 7 days, inspiratory effort, this was associated with non-survival. So the patients of radius who die were more likely to be exposed to high respiratory effort for prolonged periods compared with survival. So now, when the patient starts to breathe, we have another variable which is to control, in that case, for inspiratory effort. And inspiratory effort, if we took just that diagram, this is a mechanical breath, pressure at the alveoli is 30, pleural pressure in the case is 10, imagine that we have PIP 10, capillary pressure is 12, transpulmonary pressure 20, transvascular pressure is 2. Nice. However, if this patient have an spontaneous breath and is breathing spontaneously up to -20, transpulmonary pressure is 50. So it causes injury. Transcapillary, transvascular is 28. So there is increase in fluid at the interstitial valve, breaking of the capillars, alveolari wall, and this is the cause of patient-inflicted lung injury. So next last part of my talk. So patients may have discordance, dysynchrony, and asynchrony when they interact with the ventilator. If we have that image when we go to the bedside and we have these patients with all these characteristics, tachypnea, cyanosis, diaphoresis, activity of the all muscles, swearing, very open eyes, nasal flaring, this patient has a profound bad patient-ventilator interaction that may cause dyspnea, discomfort, delirium, post-traumatic stress disorder, lung injury, muscle injury, brain injury, and increased morbidity and mortality. So when our patients, we have taken care of the adequate PEEP, adequate tidal volume, adequate mechanical power, adequate driving pressure, not to overdistend, not to collapse the lungs, and so. And then we are decreasing sedation. We must take care of all this because also this period is very important. When we talk of the types of asynchronies or the different discordance between the patient and the ventilator, this may have at the inspiratory period, in the transition from inspiration to expiration. At the expiratory period, there are nice reviews in the literature that you can, interpret, all this. As a summary, in a recent paper published in the intensive care, they said that the most important asynchronies are, according to the expert, double triggering, when there is two inspirations without expiration. This is flow, and this is esophageal pressure, and this is caused because the inspiratory time of the patient is longer than the machine inspiratory time. When there is ineffective triggering, the patients want to breathe, but the machine do not allow this because there is an increase mostly in the alveolar pressure, not enough to trigger the ventilator. Reverse triggering, when a time cycling respiration elicits a contraction of the respiratory muscles. This usually occurs at the transition, and then auto-triggering, insufficient flow, flow starvation, which is very important, and then some phase asynchronies, which is a not real adjusting between the inspiratory time of the patient and the inspiratory time, in that case, of the machine. This causes subtle, in that case, asynchronies. For these experts, the most important, double triggering, ineffective triggering, reverse triggering, and I do not agree with him. To me, insufficient flow also is a very important asynchrony, because this may cause dyspnea and deleterious effects in the long term. It's easy to recognize, according the physiology that we know at the bedside, this. Look at that. This is a survey on respiratory therapies, physicians and nurses, and the most common asynchronies, which is ineffective efforts, double triggering, flow starvation, reverse triggering. These experts recognize between 50 and 60%. So this might be unrecognized. This is a word that we did in the past, saying this discordance, poor patient-ventilator interaction, is when happens unpredictably, very difficult to predict. These are for patients, mostly at the 7-8 date on mechanical ventilation, quasi never, during all time on mechanical ventilation, and at the beginning. That means that patient-ventilator interaction must be pursued, must stay in our mind throughout mechanical ventilation. Having asynchronies also, some people said that maybe they are associated with that of the patients, and I would tell you, the patient who do not have asynchronies is dead, because do not interact with the machine. And I advance now is not to have asynchronies, is how these asynchronies happen. And this belongs absolutely to the physiology of mechanical ventilation, the lung, and in that case, the brain. So this is a Bayesian analysis where in these patients we measured millions of waveforms with our software, and software perfectly discriminates life and death in the ICU, as all of you know, but not asynchronies. Asynchronies, they were associated with life, and probably because there are some asynchronies that we must permit at the bedside, because it's simply the interaction of the patient with the machine. But some of these are deleterious, as I'm going to explain now. In this meta-analysis, say the patient who has high numbers of asynchronies, more than, in that case, 10% of ineffective efforts and double triggering, there is an increase in the time on mechanical ventilation and increase in ICU stay. But I must admit that these are not randomized trials. These are epidemiologic trials, so the value of this meta-analysis, it's okay, but is not the definitive answer. In ICU, we must monitor everything, and everything for, almost every minute. This is a paper of Maslov saying that mean arterial pressure monitored at each hour. It seems everything is perfect. Monitoring mean arterial pressure every minute, then we catch that episode of hypotension that might be very important for the patient outcome. And unless we do longitudinal measure, we do not have this type of information. In asynchrony is similar. This is one of our patients. It seems perfectly ventilated, but this patient awakes, has a huge inspiratory effort for 40 seconds. I mean, and in this increase in effort, it may cause a stress, a strain, and then the patient relaxes. If this happened once in a night, nothing happened. If this happened once each 5 minutes, then it may cause injury. So we need to pay attention to that. These are examples of asynchronies during mechanical ventilation. Each asterisk is a double triggering. As you will see here, the inspiratory time of the patient is longer than the inspiratory time of the machine, so it's doing double triggering all the time. In several studies, it has been demonstrated that clustering, so grouping these asynchronies in cluster, this is a paper of Vaporidis saying if the patient in 3 minutes period has more than 30 episodes of, in that case, ineffective efforts, ineffective triggering, I mean, it has an increase in ICU stay and in the time of mechanical ventilation. This is an investigation that we did with a Brazilian group saying that if this patient has clusters of double triggering, the survival probability in that case, I mean, decreases when there is a high number. And this is another paper that we did in our cohort in Barcelona saying that asynchronies happen. But when these double triggering and ineffective efforts in that case occur as here in a high number, it might cause or it might affect outcome. What we found is that having clusters, let's say breathing in the ventilator with certain discordance, as I will show you here, is associated with the probability of being discharged alive. However, when these clusters, there is a high number of asynchrony at some duration, it constitutes, I mean, the probability of being discharged death is increasing, and also longer time in mechanical ventilation and in the ICU stay. Again, this is an important concept that tells us it's not the things that happen, it's how those things happen. And then our physiologic knowledge is very, very important. Just to tell you, in patients under mechanical ventilation, we should not forget the brain. The brain is very, very important because there are papers that show that, I mean, if there is brain injury, the lung is predisposed to be injured. I mean, and this is very important, particularly accounts with the patients with traumatic brain injury or hemorrhagic diseases in the brain. But also there is injury from lung to the brain, and this, on top of that, I mean, occurs with the common diseases that the patient have in the ICU. So at the bedside, we need to think mechanical ventilation effects on lung, on heart, but also effects on, in that case, on the brain. So we need to take these 4 elements into the equation. This is a nice review. A month ago was published saying that mechanical ventilation can, I mean, produce delirium, sleep disruption, or can influence delirium, sleep disruption, I mean, prolonged ventilation, maladaptive vagal purinergic signaling, alteration in CO2 regulation. These are very, very important, long-term cognitive impairment, and so on. Again, a word of caution, take always into account, in that case, the brain when you are thinking in physiology of the mechanical ventilation. Dyspnea. I cannot, I mean, escape to talk about dyspnea. This is the worst discomfort in the ventilated patient. I mean, extremely short of breath in mechanically ventilated patient occurs when they are not getting enough air or when there is too much effort to breathe. And this happens very often in patients in ICU. This is a paper that we did just to show you where we use artificial intelligence in patients with volume control to quantify the effort according to the airway pressure deformation. And then this is a tracing of airway pressure, airflow, and esophageal pressure. When the effort is normal, I mean airway pressure do not deformate too much. But when the effort is strong, as here, airway pressure really, has a huge deformation. And then with using artificial neural networks, we can quantify very accurately in each breath the severe episodes of flow starvation. This is, what we did in that study. This is just a confusion matrix saying that using artificial intelligence in real world data, mechanical ventilation, in volume square flow, very important, in volume square flow, we can identify these episodes. Is dyspnea, if this causes dyspnea, and is dyspnea important? Is dyspnea frequent in patients with mechanical ventilation? Of course, 50%, 47% of patients in the ICU, according to this study, reported dyspnea, and dyspnea was associated with anxiety and assist-controlled ventilation, and if dyspnea decreases, increases successful extubation. So it's very important, to look at, to ask the patient, are you comfortable? Do you have enough air? Do you need enough air? Do you have sensation, in that case of having not enough ventilation? Because dyspnea projects, this to the brain. Dyspnea, this effort, this sensation, this inspiratory air hunger, the sensation of the patient projects into the insula, and into the insula has effect on emotions, memory, is afference of the chemoreceptors, so on. So this may cause psychological trauma. So, and this is true. In these patients under mechanical ventilation, 2 years ago, 3 years ago, this group, 34% reported dyspnea, and ICU length of stay, look at that, this is very important, was not significantly different among patients reporting dyspnea. Okay? So, if the patient had dyspnea, they do not stay longer in the ICU. But they present post-traumatic stress disorder at the day 90. And this post-traumatic stress disorder was similar to the post-traumatic stress disorder that presented, soldiers during asphyxia, in torture action. So this is very important. This is an investigation. I work with neuropsychologists asking this, and depressive and post-traumatic stress disorder were common in our cohort of COVID-19 critically ill survivors. This cohort of COVID-19, usually, as you know that, they have strong inspiratory efforts, and the need of invasive mechanical ventilation predicted short-term occurrence and long-term persistence of these symptoms of this mental disorder, especially post-traumatic stress disorder. And we may be very happy because the patient, goes to the floor, but this patient has, a life with the family. So we also need to take care of this period. So, real world data. This is a 30 minutes in one of the patients in my ICU. This is assisted volume control ventilation. All these red episodes is what artificial intelligence tell that there is severe flow starvation, which is associated with a strong inspiratory effort and associated also, most probably in that case, with dyspnea. If I look at this, look at the 10 is PEEP, the effort, the pressure decreases further below the PEEP. So the inspiratory effort is super strong, is very high. This may cause stress and strain. Let's examine one of these periods here. This is airflow and airway pressure. The PEEP is 10. And the inspiratory effort of this goes to, in that case, to 10, to at least 13, 14 centimeters of water that we must count from here. So it's a huge inspiratory effort. And this vigorous inspiratory effort can generate large negative pleural pressure swings, excessive stress strain, on the lung parenchyma and pendeloop, which in turn may cause patient-inflicted lung injury. I am finishing my talk. Respiratory physiology is not PEEP. It's not only, driving pressure, which is very important. It's the transition from absolutely passive to assisted to the period until, the patients breathe spontaneously until weaning. This is, I believe, almost my last slide. So, We need to take care of circumstances which is my patient under assisted? If my patient is pressure, for example, is under assisted, in that case, it may be Disney. Disney is there, double trigger me account, and asynchrony that may cause injury. As I demonstrated, when associated with cluster, there is high effort that may cause injury. If this patient is over-assisted, this patient has apnea, arousals when they are sleeping, wasted efforts, and this also may cause injury. So comfort is very important, and optimal range of sedation and assistance must be pursued when the patient starts, in that case, to breathing by themselves. If sedation, if the patient have almost no sedations, then we need to really look at the assistance and the consequence of this assistance. And then we need to always ask to the patients, are you in comfort? Have you enough air? Ask these questions very often, because the translation of the physiology to these questions is very important, and this is the key point, for our actions at the bedside. The modern critical care, the future of the critical care, also is physiology. In critical care, we have multimodal data from I've been talking on mechanical ventilation, all the medical device, clinical knowledge, all lab, biochem, image, omics, whatever. This is an extraordinary source of, knowledge for high performance computing. This is what I'm doing, I try to do right now. So we are pursuing signal processing, entropy, Markov, machine learning, deep learning, large language model, generative AI, to help physicians to better understand this long process in the ICU, longitudinally, based in real-world data, second per second. For what? To have the synthetic data, to transform all this data in anonymized and synthetic data in the cloud, to pursue optimal treatment strategies for modeling, simulation, virtual RCTs, digital twins, and also we need to care, of what will be the life after the ICU. That's why in Spain there are some consults, external consultation by intensivists of the patient in the ICU, where we also would like to know what is their life after the ICU. To ameliorate depression, post-traumatic stress disorder, and so on. My last slide. I will not be here. This is my group of clinicians, or because this is the future, cross disciplines equals cross. Thank to my group. Without them, I will not be here. My group is composed by biologists, neuropsychology, intensivists, physicians, telecoms, nurses, biochemicals, engineers, data science. That's the future of knowledge in critical care. So thank you very much, and I wait for your questions.
Activate the mic. Yes, on top. Activate podium. Light. So then.
Thank you, Professor Blanc, for such an interesting presentation. Okay. Thank you, Professor Blanc, for such an interesting presentation. A lot to learn from and a lot to go back and improve our practice. I think the questions, we will send them to you. We will send them to you and get back on that because we're running out of time. But just hold on, we will present a plaque from the society, and I would like to call upon the #1 doctor in Nigeria. Glad to have him in our presence, freshly minted. He needs ICU support so much, to boost him. Professor Afekide Omoti, NMA president, to please do the honors of presenting our keynote lecturer 2 with his plaque. Thank you.
Thank you very much. Then I disconnect. Thank you very much.
Just hold on, please. Just don't disconnect.
No? Okay. Okay.
my privilege, sir, to present this award of appreciation on behalf of the Intensive and Critical Care Society of Nigeria. To Professor Louis Blanche for serving as a distinguished keynote speaker at the 11th Scientific Conference of Abuja 2026. Thank you very much, sir. We appreciate it. We enjoyed your lecture tremendously. Thank you, sir.
Thank you very much. I really appreciate. Thank you very much.
So while our enemy, so Professor Blanc, we'll have this at maybe the next World Congress. We'll hand over the plaque to you in person. Thank you.
Thank you very much.
Thank
Bye-bye.
you so much.
Bye-bye. Take
Thank
care.
you. Bye. Enjoy the rest of your day. Thank you very much.
Bye.
A round of applause for him. So while we'll have the enemy president, I will just give him to give us his goodwill message. Thank you, sir.
Morning, everybody. It's indeed an honor and privilege to stand before you to give this brief goodwill message on behalf of the Nigerian Medical Association. I had to pencil something down because this area of medicine is probably one of the most eminent and important areas of medical practice we have in the world, let me say so. So permit me to stand on whatever protocol had already been established. But let me just say, the chairman, the members of the organizing committee, and the executive members, distinguished colleagues, ladies and gentlemen, it's with great pleasure and deep sense of respect that I stand before this distinguished gathering of intensive care practitioners, researchers, and healthcare professionals who have dedicated their lives to the care of the critically ill. On behalf of the Nigerian Medical Association, I extend warm greetings and commend the organizers for convening this important conference. Critical care medicine presents one of the noblest expressions of our profession. When illness strengthens life itself, when uncertainty fills the air, when families cling to hope, it is the intensive and critical care team that stands at the front line. Your work demands exceptional knowledge, unwavering vigilance, technical excellence, compassion, and courage. Day after day, you make life-changing decisions under immense pressure, often sacrificing personal comfort so that others may have another chance at life. The events of recent years, particularly the COVID-19 pandemic, reminded the world of the indispensable role critical care professionals. While many, including my humble self, retreated from danger, you stepped forward. You walked through exhaustion, navigated limited resources, comforted grieving families, and fought tirelessly for every patient entrusted to your care. Nigeria indeed owes you a world of gratitude. Thank you very much. As we gather at this conference, we must also reflect on the challenges confronting critical care delivery in our country. And this includes inadequate critical care infrastructure and an uneven distribution of ICU facilities, shortages of trained personnel, including intensivists, critical care nurses, respiratory therapists, biomedical engineers, etc. Rising healthcare costs that place advanced care beyond the reach of many Nigerians,
workforce burnout and migration, which continue to strain our healthcare system, limited local research funding and data systems. Yet, despite these challenges, I remain optimistic. Across Nigeria, we see dedicated professionals building stronger critical care services, establishing training programs, embracing innovation, and conducting research that address our unique healthcare realities. This resilience gives us hope. The future of critical care in Nigeria must be built on several pillars. First, investment in infrastructure. Second, investment in the people. Third, collaboration with teamwork. Fourth, research and innovation. And finally, compassionate care. Dear colleagues, your specialty embodies hope. You stand between despair and recovery, between crisis and healing. Your expertise saves life. Your leadership inspires younger doctors, and your dedication strengthens the entire healthcare system. As president of the Nigerian Medical Association, I assure you that the association will continue to advocate for improved healthcare funding, better welfare for healthcare workers, stronger residency and fellowship training, and policies that enhance the quality of care available to all Nigerians. May this conference provide a platform for learning, collaboration, mentorship, and renewed commitment to excellence. May the discussions held here translate into improved patient outcomes, stronger institutions, and a healthier nation. Thank you for your service. Thank you for your sacrifice. Thank you for keeping hope alive in the most critical moments of human life. I wish you a successful and rewarding conference. God bless the intensive and critical care community. God bless. Thank you.
Mr. President, we are privileged to have you. Out of a busy schedule you have, you came in to assist us. Thank you very much. And ophthalmology doesn't need mode of critical care, except maybe penetrating injury or something. We should have oculocardiac reflex. So you also have. So we have some productions from this ESCO. One on branded by neurological criteria published. This is the guideline. And I also have the national standards for intensive care services in Nigeria. We have a sort of junks happening. And as NMA president, it's also important because that will safeguard the safety of the practice for the benefit of the public as well. So we want to present this to you as the guardian of public safety, public health safety. And then you also help us launch this. It's important that every chapter of NMA should have access to all these documents. These are products of our efforts to make sure that we create the more decent space for the practice of critical care in Nigeria. And it should concern NMA as well. So you find time and read through it and see how we can popularize it and make it available in every space that practices medicine. So thank you very much. And then you're going to launch this. You can go free of charge. Thank you, sir. So we call on Professor Sanusi to help us present the certificate. He's not going to stay too long. Prof, help us present this to the #1 doctor in the country. Good morning, sir. Welcome, Professor Dati, our NSA president. This is the umbrella body consisting of anesthetists and intensivists as well. So he's just working now. Ma, to our NMA president, #1 doctor in the country.
Professor Omoti. Good morning, sir. On behalf of the Intensive and Critical Care Society of Nigeria, I present this certificate of appreciation to you for the time you have taken out to be at our conference and for your contribution. We do not take it for granted. Thank you very much, sir.
Yes. Yes. Sorry. First, let me appreciate the society for honoring me and inviting me here. He has told me something about launching. Don't worry, I will not disappoint the society. I will do something significant. In truth, we are very busy at this period. By 2, we'll be at the National Assembly to present our position in the public hearing on 2 bills. So, and then for those who follow NMA activities, you will see that from Monday, we had an emergency NEC meeting, and by yesterday, we had meetings with various groups resolving the crisis in various states in Nigeria, NMA. So we've been quite busy. I had to leave one of the meetings now because my sister here will not forgive me if I don't show my face here. So I had to come. So I will stay a little while longer before I leave because I have to. Thank you very much.
Thank you, Mr. President. Thank you, sir. I'm very gentle. Which one our guys? So the next is our panel discussion, our panelist time. So while we are trying the panel, I'll call Dr. Muyiwa Rotimi to please come and take charge of. Thank you.
Good afternoon, distinguished ladies and gentlemen. I want to believe that we've been enjoying ourselves. It has really been a wonderful conference since yesterday. And we've come to a very, very important aspect of this conference, which is the panel discussion. And we have distinguished personalities that have been invited. The LOC did a very, very great job in carefully selecting these people so that the problems or the issues we're having can be addressed and we can have a good way forward. So I'm going to invite them forward and we have a wonderful time. Thereafter, we can have question and answers from the audience. So I have the honor of inviting the NMA president that just finished giving a speech, Professor Bekide Ernest Omotli. A round of applause for him, please. Thank you, sir. Also, we have here this morning Brigadier General O. Adoli, Commander 3 Division Medical Services and Hospital, Maxwell Kobe Cantonment, Jos Plateau State. A round of applause for him, please. We also have Dr. Yakubu Agadi Amadi. He's the Director, Strategic Purchasing, National Health Insurance Authority. You are welcome, sir. A round of applause for him, please. As part of the panelists also, we have our very own Mama of Critical Care, in person of Associate Professor A.A. Sanusi. She is a consultant, anesthetics, critical care physician, University College Hospital, Ibadan. The first president of I-CCSN. You are welcome, ma. Then we have Professor B.B. Oshinaike, the immediate past president of I-CCSN, consultant anesthetist, intensivist, University College Hospital, Ibadan. You're welcome, sir. So the last person is on his way. So we'll continue and he's going to meet us here. Thank you very much. Yeah, so I warmly welcome all our participants, the panelists rather, for this panel discussion. So, and the theme is sustainable financing for intensive care units in public health sectors. I want to talk about the challenges, opportunities, and the solution. So I will first ask Associate Professor Sanusi, from the public sector, what has been your experience? Because we need to identify the problems so that the eminent personality here can have a feel of what we're actually facing. So what are the challenges in the public health sector regarding critical care? Can we have a microphone, please?
Oh, thank you very much, Mr. Moderator. Well, we're all Nigerians here this morning, and one way or the other, either we have had, patients close to us going to public ICUs, public hospital and requiring ICU, or we've heard about some. And then what are the challenges in the public ICU? Well, first of all, when you talk about the ICU, you talk of structure, the infrastructure, the staffing, and then, of course, a major chunk of that comes to consumables. So first, starting with structure. Well, I would say most public ICUs, they have structure in terms of building, although that structure is incomplete because the equipment may not be, actually adequate. Now, the major challenge, and of course, one thing that goes for the public ICU is that we usually have, staffing in terms of physician, intensivists, in terms of critical care nurses, we have staffing. But the major challenge comes to consumables and the day-to-day care of the patient. And of course, when that becomes a problem, when that occurs, you have a problem in our hands. First, patients have to make deposits to get into ICU. That's the first bottleneck. Then patients have to to pay on a daily basis for the consumables that are being used. And quite often, you may not even see some of these relatives, for several hours in the day. Sometimes they don't even show up at all, following the admission. And that becomes a burden to the ICU management of patients. I think I want to stop there for now.
Thank you very much, ma'am. So while she was talking, we have another panelist that just came in, person of Dr. Zakuri Usman, the former Commissioner of Health, Kogi State, Senior Technical Advisor to Kogi State Government on Health System Strengthening and PHC. You're welcome, sir. A round of applause for him, please. So, Professor Oshinaike,
you have an idea of the issues in the public sector, in the private sector. What can you say are the major issues and also the effect on the patient outcome in these two sectors?
Yeah, thank you and good morning, everyone. Financing or poor financing of ICUs in public health sector is a major issue when it comes to training of doctors, intensivists now, because you have a situation where patients, let's look at the public ICU, for example, as Professor Chanusi mentioned. You have patients who are not, even despite the fact that even the fees in this, the fees in the public ICU are not that, if you compare to private, they are wide apart. Even with that, patients are not able to afford this cost of care because it's out of pocket all the time. And what happens to the patient, the number of patients you have in the ICUs? You have very low numbers of patients coming into ICU. And you know, in teaching hospitals, it's a teaching facility to train your doctors to become specialists also. And so if you don't have enough patients coming in, it's going to impact on the training. You don't have consumables to use for the patients, it's going to impact on the training. You have someone getting trained as an anesthetist or intensivist, and basic procedures that persons should have done while undergoing training has not been possible. And you have somebody qualifying, which, I mean, is actually something that shouldn't be. Qualifying and not able to do basic things. Why? Because those things were not available while he or she was being trained. And the impact of that on patient care is obvious. Because someone you have who, I mean, he doesn't know all it takes to provide effective and efficient care, now carrying the certificate as a specialist, such a person, I don't know what such a person would offer to society. So looking at the private sector, you expect that also to help. And that is why I hope this meeting, we have to see how we're going to cross-fertilize the provision of services in the ICU, in private and public. In the private, they have somehow most of the services they are supposed to offer the patients. But look at the cost again, it's quite enormous. We just listened to a presentation of the abstract this morning where we had what it cost for that patient to be in the ICU for about, I don't know, was it a week or so? Quite a huge amount. Look at the country. How many of us, even you as a doctor, can afford such care in the ICU? You see that it's impossible. That means that if an average doctor now needs an ICU care, he or she cannot fund the care in the ICU. So that means that even in the private ICU, you are not likely to have enough patients. If let's say you want to train there, the patients will not be there for training. You have few, but you don't have enough patients for training. The only thing is that, yes, if the public ICU we can have opportunity to expose our residents to such places, they can get trained. Maybe their training might be better. So ultimately, who suffers? The patient suffers. Because these doctors that, I mean, have problem with acquiring enough skill-wide training may eventually find a way to get his training optimized within or outside the country. But those patients that get exposed to him during the time, I mean, before he acquired the necessary skill, will have suffered. So the challenge, when we talk of financing the ICU, the patients suffer ultimately. And that is why we must look for alternative ways of funding our ICUs that will make everybody to access good care wherever they find themselves, whether, I mean, in the city or, I mean, in areas that don't have big facilities. So thank you very much. I'll stop there.
Thank you very much, sir. That's quite appreciated. Round of applause for him. The next question goes to General Adoli. You've had experience in building ICU before, and some ICUs are underutilized. So what can you say? Because recently I went for one accreditation and I found out that one ICU, they have the structure, but no patient. Why? Partly because the people there can't afford it. So what can you say are the factors leading to underutilization of ICUs, and how can this be mitigated? Thank you.
All right, thank you very much, distinguished moderator. I think the last two speakers have quite elaborated on some of the very obvious challenges: funding, financing, out-of-pocket payments. In my experience establishing an ICU in what I will call not a purely public facility, since it's a military facility and other ones are also military facilities, but by the nature of our doctrine in the Nigerian Army, all military facilities are open to the general public, even though not many members of the public know that. But you're free to walk into any military facility. And having said that, funding for various services are organized in line with the normal military funding and project execution. And by the nature of our system, so much depends on leadership. I was fortunate to have worked under an administrative leadership, a command leadership commander who was willing to give, he was willing to give whatever was necessary to ensure that the ICU services were optimal. And part of the driving philosophy behind his position was the huge wave of individuals, particularly in the wake of our operations, who need critical care. Individuals who have suffered severe traumatic injuries that require critical care, very often neurosurgical, having to go out to look for these not so common critical care services in private facilities at very, very high cost. So having presented the relative costs of being able to run such a facility within the system compared to having to pay for it outside, or in some cases outside the country, including the transportation and supportive care and all that, it was very obvious that it was far more economical to invest in putting in proper systems. Now, putting in proper systems within the institution to improve sustainability and limit costs boils down to a lot of factors. From my experience, even the very nature of the decision of what type of equipment to use impacts heavily on the overall cost of running the facility. And then also the extent of integrating the other services in the facility. There are some surgical services that are high yield services, like urological surgeries, for example, minimally invasive procedures. So one of the methods we use to reduce the cost of making this service available for those that need it in our facility was to tie some of the expenditures or expenses to these other high yield surgeries. So when you have a fixed percentage of some gynecological procedures, urological procedures, and other procedures being dedicated to financing ICU, you almost have a constant flow of funding for the ICU so that that initial immediate intervention does not necessarily depend on the out-of-pocket expenditure of the patient. In other words, we are able to have adequate consumables and other resources to provide the care, giving the patient enough time to stagger
their own part of the commitment. So there were quite a lot of factors, but I think these are one of the key issues. And then also mentioning the fact that from our insistence on pragmatic equipment that are adapted to our society, not just importing any equipment because it has a famous name, and then equipment that have the adequate electrical supply protection, because our electrical systems can be quite erratic. So you need voltage regulators and other things to protect the equipment. And we're happy that for the past 5 years, 4 to 5 years, we haven't had to even replace any equipment, any of our ventilators, any of our monitors and all that. So I think it partly is because of the kind of equipment that was acquired at the outset. So I think these are some of the experiences I've had in my own exposure in setting up ICUs. There are many other issues. Maybe as we go along, I'll be able to mention them.
Yeah, thank you very much. Thank you. I discovered that when it comes to procurement of some equipment, the end users not carry. The MDs just go to the company, interact with the companies, and they just order some equipment. And the equipment will come, rather that they are not really user-friendly, cumbersome to use. Even the maintenance plan, the plant maintenance agreement is not there. So you have equipment that they are very difficult to use, difficult to maintain, and at the end of the day is a loss. So going forward, it will be really nice for end users to be carried along so that we get appropriate equipment that can be maintained appropriately and also is affordable. Thank you very much.
Thank you.
Yeah, my next question goes to Dr. Agada Amadi, the Director Health Purchasing Section of NHIA. So insurance is key. And it's discovered that about just 10% of Nigerians have health insurance coverage. In Ghana, about 40%. In places like China, it's about 95%. So in your office, what is the plan? Let's even talk about health insurance generally before we now talk about ICU. Because is ICU incorporated into this health insurance? Because recently I had a patient that couldn't afford, the ICU stay was just for 3 days. And you know, in ICU, is the beginning that you don't know the end. So you don't know how long the patient is going to stay in ICU. You don't even know if the patient, after staying for 2 months, if it's going to make it or it's going to die. So if you now say, oh, this patient is just only 3 days in ICU, then it means that after 3 days, the relatives have to pay out of pocket. It's not sustainable. So what is your office doing? What are the plans to make sure that this problem are solved?
Thank you very much, and good morning. Good morning to you all, members of the society and other elders of the medical practice here. And thank you, moderator, for your kind, very kind questions. We are very
How come?
health insurance belongs to all of them. So it's not just do they have any problem? Microphones don't like me. Okay, so now we've heard a lot about the supply side. So the demand side is critical. And to give you a background, countries that are more developed are looking at financing the health system through the demand side. You empower people to be able to go to hospitals and effectively demand for services. This is the problem we have. In France, France is, I think, around 60 something million, about 68 million. Almost all of them are on health insurance, including those who have no job. And so the health insurance system is so empowered that they can load their benefit package and cover almost every new innovations that you have. Health insurance coverage in Nigeria today hovers around 10 to 11%. I think that is coming from the moderator. And then we have a situation a few years back where it was around 5%. Again, talking of statistics, and I'm not trying to defend any sector because we're all Nigerians here. When you look at 10% of the population of Nigeria, recently the minister put a statement out there. Nigeria, as we are today, and we have to appreciate what we're doing, has the 4th largest number of people that are enrolled in health insurance in Africa, about 22 million people. If you take that to Ghana, you will be doing almost 50% of the population. But this is not making excuses because we're talking of statistics and we're talking of people. There is the urgent need for us to consciously and intentionally begin to plan as to how to cover our citizens. Because the more money that goes into health insurance, the more we're able to even do more innovations and even do more efficiency savings from what we invest, and we'll be able to cover more. So speaking of generally about that, health insurance coverage in Nigeria is low, yes, but over the past few years, we've made a lot of progress. From about 18 million, within 2 to 3 years, we are already 22 million. And so I want to also throw it out to all of us as a challenge, because all of us in this room are people that are what you could call the enlightened of the society. How are we able to pass out that message to people that one of the most sustainable ways of financing health is health insurance, and get people to enroll? People are out there in the market, in the rural area, everywhere, talking about health insurance. Health insurance is what you could call maybe no longer so restrictive. We have HMOs where you can buy private plans. We have the state health insurance agencies where you can also buy policies. So we've created many avenues. If you want to enroll under NHIA today, as we sit here, you can enroll using the link. And we are doing a lot of innovations to make sure Nigerians are covered. And once they are covered, we will be able to take on more. And before I pass on the microphone, NHIA prioritizes what you're doing here so much. Because if you look at our tariff, the opening page, one of the first items you have there is on ICU. And when you have documents that are bringing up things and prioritizing them in that way, it tells you about how important those agencies are looking at those areas. I think I will break here while we continue.
Thank you very much, sir. It's amazing to note that the first page, we have ICU. That's really commendable. And we believe and we hope that you will continue to give us priority. Thank you very much. So while he was talking, a distinguished person now came in, person of Dr. Olatishe, is the MD of Zenith Medical Kidney Center. He was our chairman at the opening ceremony yesterday. Thank you very much. You're welcome, sir. Can you pass the mic to the first doctor of the nation in person of the NMA president? Sir, you talked about the issues when you gave your address. Talk about infrastructure, uneven distribution of resources, shortage of personnel, rising healthcare costs. So I want to talk more. It's not enough to just have these issues. What are the plans in sorting out or addressing these issues? The issue of brain drain, so many other issues. So as the NMA president, defending the cause of all doctors in Nigeria, because we are one first doctor before become specialist. So what's the plan of NMA in addressing the peculiar issues facing critical care in Nigeria?
Yeah, thank you very much. Good morning once again. I think I tried to list a few of the challenges, and I want to expand a little bit on them. First, let's talk about the budgetary allocation to health. There's the Abuja declaration that says we should have 15% of our budget allocated to health. I don't think we've ever done more than 6-point-something%. It hovers somewhere between 4 and 6%. So we don't even get anywhere near what is required, what we require. And it's amazing that we call it a Abuja declaration because it was declared in Nigeria. Yet Nigeria cannot do what we claim to be championing. There are many countries in Africa that do quite close to that, quite a number of countries, but we don't go anywhere near there. I think we are bothered by many other issues. Number two, I think what is even most disconcerting is that despite this low budgetary allocation for health, the trouble is how much is actually released. Last year, I heard the minister say all they got was about 36 million. So what they release to do things in health, capital development and all that is so minimal. And that is where the problem is. And that's in addressing that, before I go on, is we are already talking about advocating for improved budgetary allocation. That is definite. But we're also interested in ensuring that the money that is budgeted for is actually released. And not just released, we create monitoring systems to ensure that the money that is released is used for what it was meant for. Because those are steps, different stages that money vanishes in Nigeria. One, there's the inadequate release, and even the one that's released is diverted somewhere else for whatever purpose and not used for what it is meant for. A lot of the developments we've had are dependent on international agencies or other bodies directly funding projects. Many times, when you depend on a government one, a lot is not achieved. But I must commend those in the private sector and, well, some management staff, some hospital management that have done so much to ensure that there are facilities for intensive and critical care. Now, I think as a society, and maybe us as an association, we should partner to educate those who are in government to ensure one simple thing. The problem we have in Nigeria is that those in government and those who have the wherewithal would rather leave this country and go somewhere else for treatment. However, there is one area they cannot escape if they need it, and that is this intensive and critical care. So why don't we use that to educate them? That if you will not provide treatment for malaria, you will not provide treatment facilities for other things, at least ensure that we have adequate facilities for intensive and critical care. Not because of Nigerians who you don't care about, but because of yourself. Because by the time you need intensive and critical care, there won't be enough time to board that plane, to go to France, to go to UK, to go to anywhere you want to go to. So I think that is one area we should explore with those in the National Assembly and those in the executive of the federal and state governments. It's a shame that you find many state governments that cannot boast of one, just one, intensive care units in their states, except maybe the ones provided by the federal institutions. And it's not acceptable. If this profession or this group, the intensive care family, is responsible for standing between life and death at the most critical time, then we must ensure that at least keep people alive so that they can at least pursue other things. So we must ensure that government and those who have the wherewithal invest in intensive and critical care. And it's not just the government, actually. There are private individuals and other funding agencies that if they know the importance of this area, they may invest more. I see more people now more interested in investing in kidney, renal things, and things like that, transplants and all that. They're coming up. But all these areas also will still depend on intensive care when things go wrong. And if we don't invest on the intensive care aspect, then we'll still be losing people. So we need to use this opportunity to ensure that we do that. Then, as an association, one of our main areas of interest is universal health coverage. And at the center of that is an effective health insurance agency. I didn't even know that we have even covered up to 10%. I thought we're still less than 10. But you just told me that we're about 22 million persons in health insurance. Okay, that's fair enough. But we need to ensure that we cover much more. I don't know if we ask people here who are not covered compulsorily by their employers, maybe if you're a federal worker, how many of them, even here, are covered by insurance? You may find that the percentage will be very low. So even amongst us who are doctors, we'll have problems. And then we also have problems with administration of the health insurance. What we pay as capitation, the HMO system, and what they actually cover. Do we cover enough to keep people alive, people who need intensive care? That's the question. We need, but it's not just the number, the statistics is a matter of how many are covered by insurance, but how effective is that insurance coverage? And those are the things we must find a way to improve. We must improve it. Nobody should need intensive care and is covered by insurance. And then after a while, you say, no, the insurance no longer covers it. Pay for it by yourself. In the end, the purpose is defeated. So we're back to our out-of-pocket expenditure, which we know can never solve the problem of healthcare systems in Nigeria. We also need to ensure that it's not only those who are in employment. Well, I know that some effort is being made, but in many of our rural areas, most people have never heard of health insurance, if we're honest. I mean, those of us who come from villages, if you go and talk about health insurance, people will wonder, what are you talking about? So we probably need to do more advocacy to get us, those of us here, who have parents in the villages, to find a way to enroll them into the program. Because actually, if you want to enroll people into the National Health Insurance, NHIA programs, the fee is actually very small. And when you say, okay, people in the village, one village, up to 10 or more families come together and start paying the premium for it, you find that it's actually very small. So I think it's something that we shouldn't just, we who are here, shouldn't just be insured by our employers. We should also consider insuring our old parents in the village and our relatives, because really the amount of money is small. And for many people, I belong to a primary school class, secondary school class, where because of the advances in technology now, we have WhatsApp platforms. I have for my primary school, I have for my secondary school. Even those primary school people, I don't even know any of them again, but through WhatsApp, we know each other. But if I see them face to face, I don't know who they are. But within those groups, people are dying regularly. For many of us who have crossed 50 or whatever, You find that in your class, people are dropping them almost every few weeks. And many of them are dying because they cannot even afford health service. So we need to set up, I'm saying so because my secondary school class, we have to set up a health insurance program for them. So what I'm trying to say is that we need to start encouraging people in different platforms to belong to, different groups, different societies. We should help the Nigerian Insurance Agency to help promote health insurance. Because if we don't do that, that is the easiest way to achieve universal health coverage in Nigeria. Living into a situation where when anybody falls ill, that's when we'll start donating money. We don't help us, because that's what we always do. People fall ill, we start donating money all over the place. We should first insure ourselves. And then whatever else is necessary, we can supplement with a little donation rather than donating much more. So I don't know where I was supposed to stop in this discussion, but I better stop now.
Yeah, it's better.
Thank you.
Thank you very much, sir. So how many of us have health insurance operating? Private package. Health insurance. How many of us? Yes, NHIA, NHIS. How many of us? Very few. Charity begins at home. So we need to go and register, please, so that we can continue with this publicity. Thank you very much. Dr. Usman, the recent study found that the average cost, daily cost, ICU care is about 144,000. And this is more than twice the minimum wage in Nigeria. So how do we reconcile this? Bear in mind the goal of universal health coverage. So how do we reconcile this? Sorry, before you, please, if you have questions, kindly take note of your questions. Very soon, we'll take questions from the audience, please. And those online too, please, we'll take questions from you. Thank you.
Okay, thank you so much. Thank you for your question. If you place the minimum wage and the amount you have said for the first 24 hours caring for people in the ICU, and the country's aspiration for universal health coverage, you know, it's almost paradoxical because there's the intensive care. It's, I think, if not the most resource intensive medical service, then it's one of the most highly resource intensive medical services. And for us to achieve universal health coverage vis-a-vis this realization that are not people are not empowered enough to be able to afford them, and the fact that the costs are astronomical, I would say that some of the problems have already been mentioned. Somebody mentioned earlier the issue of healthcare financing, looking at the Abuja Declaration and how much we are budgeting for health. We're far behind a number of countries. That's the first place to start from. The second is even the budgeting. How far does it go down? The National Health Act of 2014, you know, has very clearly defined interventions. One of them is the mandatory health insurance for everyone. Another one is the vulnerable group funding, and then the basic healthcare provision fund. If we must get as close to universal health coverage as much as possible, then these are areas that we must first of all begin to look at. And someone has mentioned about 10 to 11% coverage for the national health insurance scheme. If we're there, and most of the insurance cover does not even include intensive care for our people. And where it does, maybe the first 1, 2, or 3 days, and thereafter we revert back to out-of-pocket expenditure. So I think for us to inch anywhere close to universal health coverage in the face of the prohibitive cost of intensive care, the National Health Insurance Authority must expand its coverage, and one of the things that must be included there is intensive care. Right now, everybody will agree with me that intensive care now is basically for those who can afford them, not on clinical needs, because the cost is outrageous, and it's not the cost of the people who provide service, but human resource, consumables, and machines. So unless the health insurance has a way of, covering that, we'll have issues. And I've forgotten the name, sir, but he spoke about, cost containment, what they do in their own in the military facility to ensure that, ICU services are provided. They do cost containment because of the high turnaround, high-end surgeries, like the urological surgeries, like the gynecological surgeries. And those, provide, at least for the first few days, for people who require this intensive care. Facilities can also adopt that to ensure that at least people who need clinical care, intensive care, are provided that not just for people who can pay for them. There is also, the Basic Healthcare Provision Fund coming from the federal government, from donors, and from philanthropists. And I think about 1% of the consolidated revenue goes into Basic Healthcare Provision Fund. So one other area is funding preventive care and primary health care, such that at least the progression to the need for intensive care wouldn't be there that much. Also, I think there's the emergency route. The gateways are, there's the National Health Insurance Authority, there's the Primary Healthcare Development Agency, and I think the third one is the emergency care. And if that can also be expanded, to provide some form of cover, especially for the vulnerable people who cannot afford that level of their cost. I think overall is, if payment for intensive care is going to continue to be paid from the pocket, then there's no way that we can inch anywhere close to, the universal health coverage that we're talking about. I don't know whether this is okay.
Thank you very much. Well, I appreciate it. And my next question goes to Dr. Latishe. You've been in the private sector for a round of applause for NFA President. So you've been in the private sector for a while, and I'm sure you've had some challenges meeting up with ICU financing. So could you just share your experience with us, and also give us an idea of possible models that you've been using and that can be used to address these issues regarding financing ICU?
Yeah, thank you very much. Critical care, ICU, ICU availability, you find out that a lot of the hospitals, like one of the speakers said, is not readily available. And that's why you see the ICU bed is most sought after in most standard hospitals, whether private or government. And the reason is very clear. There are not too many ICUs, standard ICUs that are available in the country. And like we said yesterday, the cost of setting up one is enormous. You know, I mentioned about you need on the average, a 10-bedded ICU, you need a minimum of $1 million to set it up, because you must have, it means you must have 10 ventilators, you must have defibrillators, monitors, you know, a lot of things, you know. You must be able to do arterial blood gases and a lot of other things, oxygen supply, a lot of things that you will need in the ICU. Then even the manpower, you must have ratio 1-to-1, and we know where we are in the country at the moment. So apart from the physical infrastructure that is not available, you also find a situation where consumables are also very difficult to get at the right time. So these are a lot of challenges for both, whether government or private hospitals to surmount. And then you find a situation where power is not stable. If it's available, it's not clean, is interrupted. And so they damage a lot of these equipment. So you don't find too many standard ICUs in the country. Now, how do we go forward? You know, the meeting is meant to solve problems, and then not just talk about the problems and we go away after gathering here. I mentioned yesterday that a lot of wealthy people in the country, you know, we need to look at that part of our society. We have quite a number of, there's so much gap between the poor and the rich in the country. So those wealthy people, rather than put their monies in healthcare, they are happy to put it in oil and gas and banking, where the turnover is very fast and they can palpate it immediately. Unlike in the hospital where you talk about 10 years on the average, you know, none of them would be willing to wait for 10 years. So government must come up with incentives like the one I talked about yesterday, where you're putting your money, if you're wealthy and you want to put your money in the health sector, they can say, okay, well, tax-free. Because as you are aware now, there is tax on, if you put your money in fixed deposit, there's a tax on it by government. If they can take off, say, okay, well, if you're putting your money in the health sector, we are going to give you tax holiday on that fund that you're bringing into the health sector. Maybe that will encourage wealthy people to invest their money in health. We need to do more. We are 230 million people. Nobody will come and solve our problems for us. It has to be local solutions. And I'm one of those people who have always talked about looking out for the local solutions to solving our problems. Every society has its own problem, so we have to figure out our own. So one of the things that we can do differently is also when we have these standard ICUs, they need to be off national grid, because that's one of the things that damages this equipment so fast. We don't have the big companies manufacturing this equipment in the country. So the issue of placement are not there. They're even finding it difficult to trust us. Some of them are here, Draeger, GE, and the rest of them. The cost of maintenance, if you sign a maintenance contract with, I have one running with GE, for example, to cover so that you don't have downtime. Now, those contracts cost millions of naira per year. I'm talking from experience, per year, to get GE to do turnaround maintenance, routine maintenance for those equipment. You will pay through your nose. So the companies also need to begin to look at their operation model in Nigeria. I know they are not willing to take so much risk. Our environment is a little bit hostile, let's say the way it is. And so they are not, those multinationals, they are not willing to take the risk they take in other parts of the world, where they place this equipment, and when new models come out, they are quick to replace them. We don't have that kind of, you pay at once and you pick it up. That's the kind of thing that in fact, you pay on ground and then they manufacture. They're not willing to take any risk in Nigeria. So I'm sure some of them are in the room. They need to take this back to the feedback to their bosses that, look, the environment is pretty stable. We can begin to have a situation where these equipment you can place in a government hospital. You can even set up these ICUs for the government, and then in a PPP kind of arrangement where the companies directly set up the ICU, and they will make sure that that's another model. They will make sure that they maintain those equipment. They will make sure that the turnaround time, the downtime is so short. That is the only way to have our ICUs running, and then that's the only way to fund it. The finance will have to come from the private. We should not look at government alone. Government doesn't have all the funds, especially now that the government revenue is shrinking. You have a situation where you have to turn out. Of course, most countries that we look up to, it's the private sector that drives health. If you look at the US, you won't find government putting money directly in hospitals. They are owned by private individuals, some missionaries and all that. They are the ones who own these hospitals, and they manage them well, and they make them very efficient. I know you will ask me that if we make everything private, what about the poor? The poor people the vulnerable in the society can be protected. The primary health sector will still remain to take care of these ones. And then if they need tertiary care, the health insurance agency, Nigerian Health Insurance, can cover that gap for the poor and the vulnerable. And of course, government is still there to play the role of regulating and then making sure that we should look at the Indian model. That's what they are doing. The government hospitals are also down, but the private ones are running. They are now listed on the, what do you call it now, stock exchange. That shows that private people are bringing in money into their health sector. You see hospitals look like hotels in India. They started from somewhere. We can copy their own model. It will work for us. And then they have population. Our own population is also growing. So we can look at that model and see how did they do it. They started with looking at doctors, giving them loans, single-digit loans, not the 27% from commercial banks. You won't come out. You cannot run a hospital with loan from a commercial bank. All these banks, it will not work. So we should look at how did the Indians, how did they get the models right? They went about giving big, serious practitioners single-digit loans. They gave them landed property to build, and then they gave them moratorium of so many years. That will bring in more funds into the health sector. You don't expect government to do everything. Once more funds comes in, more people will access this care that we're talking about. The NMA president was talking about when people need ICU care, they cannot go out. It's very clear. These are situations where you're not even in a position to take those decisions. Once you go into the ICU, you may not be around. I've had a very big person in the society in our ICU, and by the time he was aware of where he was getting angry. They restrained me, they hold me, they restrained me. Can you imagine, So you are not in charge anymore. Somebody will be taking decisions for you. So if we have health decision makers here, people in government, please build an ICU in a state where you govern, such that they can take you there if these things happen. We all need to have it in all the states of the federation. Anybody can end up in the ICU. All of us here, anybody. So we need to have an ICU that works. At least let's have those standard ones where if you have such situations, you can be taken there and you get the best of care. We will have to do that. And then, like I said, on the final note, I will say that this funding will come from, we should look at the private sector. They are doing a lot. They're already driving other sectors, oil and gas. You can see everything that is going on now, like the banking sector. And every year you see them declare wonderful profits. That can also happen in the health sector, if we have more players, more funding coming in there. Thank you.
Thank you very, very much, sir, for that valued input. I want to give opportunity to those in the audience. Please, do you have questions? Please kindly signify by raising your hand, please. We have Dr. Oju, and Mr. President, NSA, and Dr. Paul.
Thank you so much, panelists, for this opportunity to speak or add to this and also ask a question. My question is on budgeting. I've heard that we had this warning that there is budget, but it's not being implemented. So what role can the ministry play to prioritize health budgets? Because a journey of 1,000 miles is a step forward. So what can we do to make sure that health budget is being released? Because while crying foul is there, we're not getting it. So something must be done to get it, so we can move forward from there. Number two, somebody spoke about EMT pathway. Recently, I have worked with the NIMSAS program. I know that EMT pathway is not robust enough to take IC, because to transfer a patient is about 35,000 naira from one point to the other. We'll be talking about IC with 35,000, and I see the bills before it will get to Abuja and return back for payments. I deeply worked with NIMSAS for a long time, so I know what I'm saying about that. So can we, in creating the budget for health, create a budget for ICU too, particularly? Let ICU have its own budget, since it's an area that is novel, an area that must develop. Whether we say that in foreign countries that ICU health is not being financed by government. Yes, there's also some countries in the world. I have the opportunity to know that some countries in the world, basically also for the budget, finance issues of health. The private sector is there, but the government has its own role still in financing. So we can actually say this is a novel area. Why don't the government prioritize it and make sure that we have a budget for the growth of intensive care in the nation? It's a win-win for all of us, since nobody is exempted from ICU. And then two, the manufacturing. Most developed countries like India, the rest of them, you see, they manufacture most of these equipments within there because it is cheaper to manufacture within. They are not importing them from outside. So let the government create the avenue for these companies, GE and the rest of them, to set up factories. We used to have PAN in Nigeria, motor companies in Nigeria, Innocy Motor is manufacturing. It's still technology. We can actually manufacture these ventilators, these monitors within our shores. It will reduce the cost of several billions. My friend, our Zenith man who has sponsored us here, is talking about buying them, flying them in dollars and so forth and so on. That cost will be up, and then the cost of ICU generally would drop in setting up ICU. That's where the problem is, because a lot of ICU are not being set well. Because number one, the cost and manpower. Then the rest can take place from there. Thank you so much.
Thank you very much. Who would like to respond to question on budget?
Thank you very much. I think for budget, because NHI is under Ministry of Health, so I can really talk a bit about that and the experiences we've had in the past. Two big issues. One is about the money we're getting, and the other thing is the value we are getting for even the little that we're getting. One of the meetings we've had with the office of the budget office, it's even about utilizing what you have budgeted for you, even the one that is released. On many occasions in the past, Ministry of Health has returned money back to the Treasury, and that has discouraged them. So the first thing is, how do you plan your budget? if you do budgets that you're not going to be able to implement, then you have the issue of having to return money back to the treasury. And the following year, the finance man looks at how you're able to use these things. And then when you ask the following year, he doesn't. NHIA usually doesn't get any budget. We are self-paying agency. We don't draw budgets for personnel or any other thing from government. But this is the experience that we have. So we need to look more at the process of developing those budget planning. How realistic are the things? How realistic are they? And then the policymakers, what do they understand? How do they understand your budget? We need to go more into the economics of what we're doing. We are talking about intensive care here. The policy maker would understand, if you're talking in terms of economy, what do you save by saving a life? What is the value to the nation? What does the nation lose? And I speak this from the point of view of looking at health as a key issue in economic development of every nation. So when you look at health from the point of welfare, and you make politicians and policymakers to begin to assume that when they put money in health, they are helping the people. And then we will continue to struggle the way we are struggling. The point is, how do you convince policymakers and people who approve your budget that the money you're putting in health can lead to economic development? And that's what they probably will understand even faster. So I think this is what we need to do, even as we talk about intensive care. I've heard a lot of things here. We have the example of COVID-19 to show where people who also highly placed couldn't be evacuated out of the country. So these are things that are staring us in the face. Today, we are talking about a sector that doesn't give you time to even get an air ambulance or anything. There are things that you must do. And then, so when we are talking about planning, these are the things we should be gathering. We map where are the ICU centers, what are the capacities available. We should be ready with those if we want to go and advocate for anything. I've heard here about, geographical disparity of location of ICU centers. These are issues that must be addressed by government. And increasingly, Dr. Olatici has made mention of something. The provision of healthcare, the supply of healthcare is different from demand. Government must be involved in also making people capable of effective demand for health services. And that's where we are. The private sector can bring in supplies. They can, but private sector is not going to put money in people's pocket to go to the hospital. So they can't effectively demand what you are even ready to provide. And once they can effectively demand, the private people who are rich can put their money in that sector. So we have an example of also about leasing. Now that I have the opportunity, I will talk about all this. Leasing. One of the plans we had at NHIA was to see how we can provide them that environment, because we can use the economy of scale. We have population, 22 million. So if we go to GE, for example, using that number, that's what pharma companies and OEMs are interested in. Do you have numbers that can consume what we will produce? And you can negotiate. We've been able to negotiate 50% of the cost of cancer medications for enrollees of NHIA through the number. So these are areas that there are so many innovations we can go into as a society. to see how we can make this practice better. While answering the question on the budget, I think I also touched on a few other things. Thank you.
Okay, somebody mentioned the last speaker, also in the audience, talked about asking these big companies to come and set up their factories in Nigeria. I guess it goes beyond us here, and I'll tell you why. We would need to solve our security and energy problems first before these companies will come here. Trust me with what I'm saying. I'll give an example, practical example. The man from Drager, they are operating from Ghana. Why are they not in Nigeria? I asked him that pertinent questions. Mr. Buhari is sitting somewhere there because they are the ones equipping our ICU as I speak. He would choose to operate from Ghana and not in Nigeria. Ghana has a population of what? For 30-something million? Or so? Less than 50 million. We are 230 million people. That on its own should be an attraction for them. But if you ask them, what are they seeing in Ghana that they're not seeing here? Maybe better stable power and then security. So those are the two issues that must happen first before you can get those companies to be stable here. And then that way you can now see them manufacturing, and then we have as new models of these equipments come out, they will make them available to us. So that's one of the things that we must resolve first as a nation. Then talking about, he also mentioned how do we get our people, our leaders, to increase the budget. The NHIA boss here has already mentioned that even the budget that they are giving us, sometimes we're not utilizing it. Again, it will still boil down to policymakers. How do you get them to believe in a health sector? We still have a lot of advocacy to do. Our Human Development Index is very low, 0.56 as of today. And how do you come about that? It's health and education, I think. Those are the two things that the inputs that you must have. So very low, and the reason is not far-fetched. It is because you still need, so more of us here, health workers, we have to be actively involved in politics. Maybe those that are interested, that's the only way to get more budget in, and then get people in who will believe in the health sector, healthcare. Let them know the importance. You will see a country like the UK, it's top on their priority. That's why they have the NHS. That's number one thing that they cater for first. They believe that if citizens are healthy, then productivity will improve. So we also have, as health workers here, the challenge is, let us all get the people around us. Some of us are physicians to some of these people. Keep telling them that, look, health is everything. And so that you can now have more budget, and then the implementation will also be better. Thank you.
Thank you very much. So you need to be involved in politics. Just tell your neighbor, be interested in politics. So, no.
Thank you very much. I think I agree with most of what you said, but now we have to find a way of dealing with the out-of-pocket treatment. That is the most immediate. And over for a year or so, because what we see in the ICU, say, how can we solve this problem? Involving the private sector is key. And I'm going to speak from the religious point of view, Islamic point of view. The richest man in Africa is from Kano. The second richest man is in Kano. And we have many that the province will not be able to access them, deal in cash. So what they are doing in Kano, you go to AKTH, you see buildings, I know that our new labor ward theater and the ward was built by someone that said he doesn't want his name mentioned. There are many of them. So what they want is accountability. So we can go, what I'm thinking, we will need the I-CCSN, we need to repeat this panel discussion to maintain the momentum at the next NSA meeting in Kano. And that is, then we can gain access to the EMIA. The EMIA has access to these people. The problem is that very few Nigerians know what is critical care, but thank God the COVID has done some, what do you call it, PR for us. For the first time, the anesthetist picture was on Times Magazine during COVID. So we can now maintain that momentum. So in Islam, there is zakat. And zakat is a stipulated amount, you know, that the wealthy will have to part as part of the religious obligation with a percentage every year. And it's huge amount of money. So we can access that because the critically ill patient that is now an indigent patient cannot pay, cannot even talk. So they will buy the idea that this fund will go to them. So there can be an endowment fund, whatever, with trustees to manage the fund. And we have to carry along the committee of CMDs. We should interact with them, and then they do the advocacy, the emir. We can get to the Sultan easily. That one I can guarantee you that. You get that support. They have Council of Ulama and so on. It's a huge amount of money. Now, what they will do, the government will be happy to say, oh, all your, because most of our ICUs are in the public hospitals. And we will include the military too, because you need to be carried along. So there will be a percentage say, okay, if the cost of ICU care is about 100,000 naira per day, that fund probably will address, maybe would take off like 50%, whatever percentage is a relief. And it can improve. So when they see that happening, they will invest more. That's from social point of view. And maybe where they will interact with the NHI, it will come. Now you carry along the Draga and his colleague. We make them that they can, what we need is that every 3-5 years, this equipment needs to be replaced. They can budget, these people. They'll be happy to do that. And then the cost of care will come. And then when energy is addressed, we can now look at the Indian model to build on that. But first, you need to take care of this out-of-pocket issue. And people will be very happy. This, the Dangotes, the $10, and so they will be happy. You know, they are a clique, they have a club. And when they buy in, now that they are doing well, they will be happy. Now, the problem with the politicians, they have building, they want to see building and come to commission. So I was thinking how to say, okay, we almost got someone who had a relative in the ICU and he promised to do, he has a lot of money, but somehow we lost track of him. You can say this ICU was re-equipped by, you know, we can put that kind of thing. But first, let us access this zakat. There is a huge amount of money there. And then people in Kano and elsewhere that are Muslim, they give this zakat. It's huge amount of money. So committee of CMDs, advocacy, a trustee endowment fund, you have trustees, and then they determine what percentage goes to every patient. We have the data. We can always produce data in a year. We have so number of patients, and that can be easily, and then they can be improved. Thank you.
Thank you very much. Do you have something to say?
Thank you. When Dr. Latishe was talking, there were a few things that came to my mind. You know, talking about private sector, how private sector can help in this scenario of ICU? Right, you mentioned the Indian model, which is good, but our own private sector here, I'm sure nobody is running ICU at a loss. I mean, the private sector, definitely. So if we get our rich people to actually invest in private ICUs, like the Indian model, all the specialist things they do, you know, which is, I mean, for which the owner gets some, you know, some kind of tax relief or whatever, or they get loans at very, you know, minimal rates. There is a tag to it. Like, you know, there's a minimum number of indigent patients you must treat in a year for you to maintain that particular system. So if we do something like that, there's a minimum that must be returned to maintain the ICU cost, you know, of the indigent, you know, patients. So there are ways by which we can go around this so that we don't have to go cap in hand to actually, they know that they're getting value for their money. They will get returns on their money, but out of this return, something goes, you know, to maintain the system. Like all these other systems we're talking about. The man that does not work, has no job, and is fully insured, there's a reason for it. Because if it's not insured, it will become a problem to the rest of the society. That's why other governments pay people that are not working. So we have to look for a way by which we can actually, you know, integrate the rich into maintaining or providing some service to the indigent, you know, in the society. And I think that is something that we can work around with. Now, coming to the public hospitals and public ICUs, generally the public hospitals, there is also something we can do, you know, talking about procurement, supply of equipment, and so on. Now, in many countries, equipment are usually standardized. It's not like in Nigeria where, you know, you buy your own brand, I'll buy my own brand, and there is nothing that connects us. And that is how the vendors can, you know, take advantage of us. Now, if the government hospital will say, for ventilators, we identify 2 good brands or 3 good brands, these are the ones we're going to be buying, and the company knows that you are going to consistently, you know, maintain that as long as they are good enough and they are providing service, you can bring down costs. And that can go, you know, that can go round. So there are ways by which you can reduce this cost. Thank you.
Okay, I want to thank the panelists, but my question will be a bit different, because I noticed that we'll just be saying the same thing over and over again. Let me ask you a question. If a government official knows he cannot go overseas for treatment, if a government official, a governor, a minister knows that there is a law making it illegal for them to leave the country, to go overseas for medical treatment, are we going to be educating them on this? They will be the one to learn it. They will be the one to know what should be done. In Burkina Faso recently, the government made a law making it illegal for any Burkinabe to access education overseas. Before you access education, whether you are private or public, you must get approval of the Executive Council. If you look at what Burkina Faso is doing, in the next few years, Nigerians will go to Burkina Faso to start accessing university education in Burkina Faso, because their own system will grow. So I see a situation whereby in Nigeria, because government officials have access to funds easily. When they are sick, they go overseas. Whatever we meet in conference, we discuss, we write communiques, we'll do whatever we can. They are not willing to do it because they can escape. As long as we are allowing them to escape through NMA, this is my question ought to have been addressed to NMA. We are not doing enough. We need to find a way to do whatever we can to get them to make a law, making it illegal for anybody in government to access healthcare outside the country, both himself and his families. It will make them to prioritize healthcare, increase the budget, and build it. Another thing I would suggest is that the basic healthcare provision fund gets allocation directly from the Consolidated Revenue Fund, and it has 4 pillars. So I'm suggesting that ICU should be included. That law needs to be amended. The NMA and other stakeholders need to lobby government to amend that law to include ICU. At least we'll be able to get adequate funding, where we now pursue other items. Thank you.
Well, the doctor has a very radical approach to what we are discussing. What you have said is on point, really on point. But would that happen in our country? No. The policy makers, the people who pass that law, they are part of those escaping. So it may not be possible. Nobody will pass a law that he will not get his hands burnt. They won't pass it. So it's a very radical approach, but that's the truth. If if that can be done, then it's the fastest cut to the solution to our problems. But you and I know that we're sitting down here, that may not fly. That may not happen, not now. So, because people will tell you, okay, well, maybe the people in government, the private ones will tell you, well, I have my funds. I want to go outside to get anything I want. That's fine by me. But if that such a law can be passed, like he said, is the fastest way to get to be home and dry. But I don't see that happening. There are people in government here. They may also want to speak to that.
I'm not in government. I'm just thinking of something. I know we have said that it's difficult to attract or make Draga and other people to come to Nigeria. There are some companies already in Nigeria that I think can be of help. For example, consumables are major problem in the ICU. There are some consumables that I find, I don't understand why those things can be produced in Nigeria. Central venous catheter, for example. Why can't we produce that in Nigeria? Is it possible? Huh? Let us execute. There are things. So, how can we as a society, can't we as a society meet these people? There are plastic companies in Nigeria, there are rubber factories in Nigeria. These are things, and what do they need? Gamma radiation or whatever to get these things. At least we produce syringes in Nigeria. So those things are, I was discussing one of them there. How much is this? 18,000 to buy this. And that is what in India, those things are so cheap because they get them produced there. They use them and discard anyhow, though they don't discard everything in India. They gamma radiate many things that they reuse because they have the facility. Okay, so I think as a society we can work on that. You'll be surprised in institutions in Nigeria, a resident doctor will spend 4 or 5 years, will not have seen or used a central venous catheter. How can that be? And we are training residents and anesthesia and intensive care. So they are basic things that can be produced. So I think we need, as a society, let's see what we can do so that these things can be produced locally. It will really help us with the cost. I will stop there. Thank you. It's just painful.
I could feel you. I could palpate the yes. Yeah, you're actually right, sir, because I think as a society, we need to be very proactive
and we need to take steps. We can approach these companies and let them know that these things, what does it entail? Because we have the market. So, and we can help them and we partner with them. It's just for us to make steps. I think it's doable.
I think I have an idea to why some of these companies still don't think we are attractive enough. One of those reasons is that they still think the cost of importation is still way cheaper than cost of production in our country. That's the reason why they're not doing it. Now, yes, because the raw materials are here. Power. By the time they want to set up that factory that will manufacture central venous catheters, and they see how cheap these things are in countries like China, you will now realize that the man would rather import them than set up that company here. And then again, let's also look at some of our laws that is also making it very difficult. Our environment is still the multiple taxations. Dr. Iseko is here. He runs a practice. He knows what I'm talking about because we compare notes, and then you see that if somebody sets up a company now, you have maybe 10 to 15 arms of AMAC coming to take tax. Different people coming on daily basis to take the same tax. And they tell you that, TV license, radio license, environmental sanitation, you need all these things, you need certificates. Those certificates, you have to pay for them. So when the man sets up such and he sees all these taxes coming, they will not add up. You close the place down. And then so these are some of the reasons why those companies are not setting up. If we can change some of these our laws, make it very transparent, it still goes down to the policy makers. Take out some of these multiple taxations and then make sure that energy is available with power. You will find out that a lot of companies will go into manufacturing. Right now, it's cheaper to import anything to the country than to make them here. That's why you are not seeing those companies. Thank you.
Thank you very much. We have a long way to go.
Thank you. I think I agree completely with Dr. Laitishe, and beyond that, at the point of entry, there's so much bureaucracy, and then at the accountability issue, somebody wants to come in to establish a company. There's a long list of who to see and what to see, and we know what happens when you see it this way, and this is not just about the health sector. Aswadi Textile, United Nigeria Textile, Arewa Textile, where are they? Because of the same problem. The energy issue, the power issue. Importing these textile items and manufacturing them here, I think is about threefold cheap, more expensive to manufacture them here than, and the ones that are coming sometimes are even of better quality. So I think until some of these obstacles are removed from the way, we're going to continue to have issues with these companies wanting to come around. The Honorable Minister's, sector-wide approach, one of the things that he has continuously hammered on is indigenous manufacturing of, health products, health consumables, and all of that. But on the side, peeping in are some of these things that were mentioned. The area I want to talk about and see, you mentioned how expensive it is for the turnaround maintenance of some of these equipment in the ICU. And I'm thinking, how possible is it for us to try to see how we can, domesticate, the turnaround maintenance without having to run to those companies at all times? Is it possible that we can have, a pool of maybe say about medical engineers that the country can train, and have them, on our grid, and then they go around to do, I'm sure that will help also to reduce the cost of intensive care services.
You have some of those companies, representatives are here. They make it very difficult. They will tell you once somebody who is not from the company touches your equipment, you've lost warranty on it. So I guess it's part of what they used to hold on to us. Like I said, let me give you an example. We have a HLA lab set up by an Italian firm called Lagiter. They are one of the biggest in the world, setting up molecular labs. They go as far as monitoring these equipments via the cloud. Yeah. So I think they've studied our environment and they've seen that these guys are easy to hold on to. They see that our laws you can just maneuver, you know, and so they set it up. They set it up for us. Do you believe that when there are updates, because it's online, when there are updates, we still have to go back to them. They will update the equipment for us. That doesn't happen in Europe, where they are. They are in Italy. Their updates happen real time. But in Africa, they update those equipments based on your yearly payments to them. So if you don't pay, they will not update your equipment. And you don't have laws that protect you. So you are open to it. You are vulnerable because they will tell you, okay, for maintenance, the engineers will have to come in from Italy. So you keep funding those movements. And then the equipment can even, if you are not careful, they can lock it from, they will encode and then just it goes off from Italy. You know, so you can see that we are still going through a lot. Those laws that govern what they do in Europe doesn't exist here. And it's like that in a lot of other sectors. Look at aviation. The kind of plane that one airline will bring to Nigeria is different from the one that they are allowed to use in some other countries. Those countries will tell them, look, listen, you have to have this specification, A, B, C, D, to operate in our country. So until we begin to stand up and really fight for what our rights are, then we will continue to have this situation. They will tell you once you touch it. I have one of our colleagues, he's not here, he runs a hospital, and his cath lab went down. And he got some engineers from another part of the country, or another part of the world to come and fix it. And then, of course, GE said, well, somebody else has touched this machine. So, sorry, we can't help you. So these are some of the things that we face that we need people in government to fight for. They will have to fight for it so that these companies know that, yes, we can really stand up and decide how we want to run our country. Until that happens, we'll still be going around a cycle.
Thank you very much. We are rounding off. Mr. President.
Thank you very much, panelists. Very fantastic ideas you're bringing up. I detest this idea that we're always lamenting. I don't know when we will stop lamentation. But if you attend international conferences, we've defined ourselves as low resource setting, something limiting. I don't just understand. Chief, let me ask you first, before I make my final comments. If you have to be the CMD of LUT, from the experiences you've gathered, you train in a public hospital, setting, university setting, and now you get your experience outside. If they moved you now, as you are now, to LUT as CMD, what would you do differently? I have my comments.
That's very difficult. In the government setting, there are so many things that will limit your success. And until those obstacles are off, I may not still do well. I may not do well in those settings. But if we are saying we really want a change, then I may succeed. Because once you really want a change, it means that all those areas where you have issues, once you are given a free hand to turn them around, then you would achieve a lot. You know, I would start by saying that the first thing I would do is to play down on the unions so that you can begin to implement policies that will work in that hospital. Because in the private setting, we don't have unions. Dr. Iseko is here. He can wake up one morning and if you're not performing, he will fire. In the government setting, you can't do that. You have to go through a whole process to get a civil servant off. You don't know who he knows. You don't know who brought him into that system. The person may be way higher up, and then you begin to have problems. So, but in the private setting, so if you're not performing, you're out. We don't allow people remain in the system when they have nothing to offer. They don't have anything to bring on the table, and until you remove all those obstacles, you will take a saint, take anybody from somewhere and then to go and run those establishments. The person may still not succeed because of these obstacles. But if as a country, as a nation, we say, yes, we really want a change, and you have somebody whose body language says, yes, we want a change, then you can begin to address some of these issues, and then it will be a better place. And then it will be easier to run that way. Thank you.
Thank you very much. So this will answer question is tomorrow, maybe the Minister of Health, Minister for Health Services, and then you have the private sector background, and then from your training, so it's easier to blend politics and public administration. A metal guy tried to make this work in the midst of all these cries. Yeah. I remember the Buhari's administration gave CMDs down around 15 million naira to equip intensive care units. These monies were given to doctors. And all of us here, everybody here is a doctor. So what happened? We're doing a study now. I didn't know you and I, we look at pre-COVID, post-COVID, what has, and both of us work in intensive care units, given to doctors. And then the thing is that when you go to the ministry and then you lay your complaints, we find it extremely difficult to see members of the National Assembly. We delivered letters, they are not ready to listen to us. So how long do we continue with this lamentation? It's like, because the thing is the emotional effects. You remember Professor Blank, one of the things he said is the effect of post-traumatic stress disorder on ventilated patients who are feeling the discomfort of ventilation. It's the same thing we experience. You work in a place where, I don't know how it is in the Badon, in Port Harcourt, this NECO, is it NECO? Even NHIS, sorry, you were getting NHIS. They don't even contribute, they don't contribute anything because they bring in their patients to the ICU. ICU doesn't have the capacity to manage in terms of provision of consumables. And the NHIS, where the money goes, I don't know. It's management that takes care of the money that comes from NHIS. And then the ICUs are on daily basis being incapacitated to function. Somebody comes in, rupture uterus, sepsis, and they bring the patient in Port Harcourt. The cost of admission is 70,000. Is it 70,000 naira? It's not more than that. It's 70,000 naira. ICUs 70,000 naira. You pay a deposit. I'm the head of the ICU now, so I'm telling you, 70,000 naira. Yes. No, I will explain two scenarios now because I'm saying it authoritatively as the head. 70,000 naira, and some struggle to pay that 70,000 naira. Most times they just come in. Most people here struggle to pay the 70,000 naira. And then oxygen is about 20,000 naira a cylinder. And if you're ventilating them, after 1-2 days, they can't afford it. And you're watching your patients, you can't pay for antibiotics, you can't pay for investigation, you can't pay for anything. Does anybody consider the traumatic effect, psychological effect on you, the practitioner? We always complain, I have sympathy, empathy on patients. But how do we feel? Someone is dying away. And then I remember when the wife of a governor walked in and there was no monitor, and I said, "Ma, could you see this woman? Your father has a monitor. This one doesn't have any. Is there anything you could do?" And they just walk away. So the thing is that most time, I mean, if you ask me, I would emphasize that Maybe you should strengthen the hands of the private sector. The only thing that it has, if private sector can also consider the poor, that is the only area, because in public hospitals, the story is the same thing. You give the money to even doctors to manage their own facilities where they are training, and they just, most ICUs, I mean, that's why we think that we should actually institute the price on the best public ICU in the country to see if any way this can change maybe their psyche. Because during COVID, you say everybody's raising money for COVID because the big men don't want to die. They are distributing money, the government responded very fast. But on daily basis, yes, because on daily basis, it doesn't affect them. But in the private sector, it will tell us that in private sector, I've seen ICU where they pay, somebody was paid 200 million naira. A company could pay, some rich individuals, like those who are in the UK, US, whose parents are here, they have stroke, they don't have issues with payments. But the poor are struggling on a daily basis. And that's why this meeting, this thing we are discussing now is, which one is feasible? Is it a hybrid method of like asking the military? I think it's important for me to even mention this. The military goes into production, it produces some software, hardware. Is it possible you take up this responsibility of producing basic consumables? Because these bureaucratic bottlenecks may not really happen in the military. If it's possible, we take over. In some places like in the US, military hospitals are standard places of care. Even their presidents are admitted to those places. If you can, because we have to be smarter than the politicians. I don't think, but they are top class pass. All of us are very brilliant people. So we should think out a way of how to, like, either we shift the responsibility of care to military centers where you produce consumables. Where you produce consumables for us. If you have a standard ICU and your cost is much less than what obtains in public hospitals, patients will flow down to the military hospitals. And people can come there to do training and all that. And then we abandon those places for, when it happened to the big men, chief will capture them and collect money and give us money. Thank you.
Our teacher here mentioned how we can protect the vulnerable. She mentioned it. One of the ways, like the India model, what they do is they give you X funds. You are going to, for that year, you have a quota. You must look after 200, 300 vulnerable poor people, and they will monitor it. These are some of the ways that you can also make sure that you protect them. They do it in India. Those big hospitals that look like hotels, you will wonder how the poor Indians still go in there and get care, because they have a clear data for the poor, and you know they enforce it. They can tell you, for this year, you are going to look after 500 vulnerable people. You must do it. Otherwise, you'll be punished. And so strong government policies can still take care of the poor people when they need tertiary care. The primary health care can take care of malaria and all those other ones. But that tertiary care, you may at some point have to privatize it. Look at the NHS. It's not working anymore. It's not. You see, you go into their emergencies now, you will spend hours before you see any doctor to come and ask you, hey, what brought you here? Because they are overwhelmed. Doctors are overwhelmed. They don't even have money to fund it properly anymore. Health cannot be cheap. Let's face it. And it's a business. You can look at the US model. Health is business. They are not joking with it. It is business, whether you like it or not. It can't be cheap. The countries that are still funding it, just wait and see how their population is growing. They're finding it difficult. The UK, maybe about 60-something million people, 65, 67 million people now. Wait until when our own country like 200 million. There's no way the health will be cheap. It cannot be. And government cannot fund it. It's not possible. 200 million people plus. It's not going to work. The only way around it is to have these models, like we said. Empower the private sector. Let them drive that tertiary health care system in the various parts of the world or the parts of the country. And then that way you will see that, and then keep protecting the poor. Strengthen NHIA that we have here. How do you strengthen it? More funding. That way they can cover more poor, vulnerable people. And that way, through them, because you have private ones now, it's working. Sir, Venus, AXA Mansa, although they're working. They are really working. We see them. They can afford to come to the private sector. So let's have more of those private health insurance cover.
But that's good. It's not NHIS the boss. Not NHIS. So the more you pull, the more the chopping goes in.
Honestly, because I've worked at NHIA for close to 25 years, I can tell you that that's an organization that you can find people with integrity. Forget what everybody says. Go to the market, to the street, anywhere with that. I'm just sharing, I won't say what I was discussing with him, but the country will face a lot of things. But to your point, what we need for financing is a blended approach. Nigeria is blessed with a lot of resources. And we have very, very knowledgeable people spread all over the world and right here in the country. Two of them are in this room, Dr. Latise and Limi here, Dr. Iseko. They are doing wonderfully well. The private sector is very important to whatever we can achieve in this country. The government sector is also important, but increasingly, the role of the government is to empower people to be able to, and I keep using that word, effectively demand care. The supply can be, the private sector is not going to empower vulnerable people to go and access care. He has spoken about the rich people, the richest people. Can they continue to pay for people who are poor? They can try, but it is the role of the government to ensure that vulnerable people are paid for. And I have made a point earlier that in France and the NHS and other countries, even in India, what they do is to ensure that even people who are not employed have health insurance, except you decide on your own that you won't have. And then we can begin to talk of pricing, costing of services. We can begin to talk of coverage, availability, geographical availability of care. We can talk of doing health technology assessment and seeing what is most important to bring them on board. I like to end with this. We are holding this beautiful discussion, and we've been talking here. How many people from Ministry of Health, Ministry of Finance, Ministry of National Budget or Planning, how many of them are in this room? We have discussed this. To them, all that we are saying here, probably you come out with a communique or something, they might not even read it. Please, the next meeting in Kano, sir, make sure that people from Ministry of Finance are in the room when you are discussing sustainable financing. We have said how South Africa continue to do about 15% of that Abuja declaration. Somebody mentioned it here today. And that's why they are different. I think Lesotho, Namibia, and some of the countries around there, consistently, they've done that. And their healthcare is at a different level. And then when we are able to do that, we should be able to ask the authorities like NHIA, how are you using the fund we are giving you? There's no 20 billion in the NHIA, sir. There's no 20 billion there. In short, NHIA, like I say, and put it on record, doesn't receive a budget directly from the government. All we deal with is premium that is paid by people. Secondly, in France, they have two budgets. So there's a budget for social protection. From that budget for social protection, they also have the budget for health insurance for the vulnerable. That's what they do. So it's budgeted intentionally every year. There are best practices, and that's why I was asking, do we have somebody from Ministry of Finance here? Because when they are doing the budget, what we prepare and give to them, they can do a lot of changes to it. And those who have, who are able to talk to the Senate president, the big people in the country, health is a right. Government must take care of people who cannot pay for themselves. We can do all the ones around premium, social health insurance, workers are paying, people who can buy. But I can tell you that there are Nigerians who this year have not seen 10,000 naira together, hold at once. There are many Nigerians that haven't seen that. And so how do they get to pay for health insurance? So we must find a way, the society collectively must find a way of making sure that these ones also have access to ICU care when they need it. Thank you very much.
It's kindly give the phone, like to final word to round up. What do you say?
Yes, thank you very much. And thank you, the organizing committee, for inviting me for this, to be a member of this panel. It's been a real privilege. But we have spoken a lot, just like it has been observed repeatedly, about the challenges, the problems. Some solutions some suggestions have come up. However, I think in as much as ICU financing is so critical, even in this climate, just like it was also observed, people have successfully established and run ICUs in a functional manner. So what is it that's different about how those people approached their own system? I can bear testimony to my own personal experience. In spite of these challenges that we have discussed generally, which I must say actually affect virtually every other component or aspect of healthcare, of the healthcare delivery system, be it maternal and child health or mental health or so many other aspects of health. So it's a general problem, but it is still surmountable if maybe we look inwards a bit more. And beyond financing is also capacity. Because one of the major issues I observed in my personal experience is the capacity of those that deliver the service, from the nurses to the specialists, the specialty team, the team management, the leadership of institutions, and the general management. So I think that sometimes financing, as huge as it might be, a problem, may still be surmounted by maybe more effective management and maybe tinkering with our internal mechanisms to see how we can actually work better with what we have. Thank you very much.
Thank you very much, sir. Final note, and let me give it to Dr. Tabutin.
Right. Thank you. On the final note, well, I have two suggestions. We've been talking of this financing. We've mentioned so many models. Now, even in the present situation in which we are, in the teaching hospitals, the public hospitals, because most of our intensive care units are in the teaching hospitals. In the public hospital, we can still look at this hybrid model that can help us to actually be able to look after the vulnerable. We've been talking about private ICUs. If we have ICUs of that standard that will provide all the care, and add on top of that hotel services. What I mean by hotel services, the way the patients are treated, the way the relatives are managed, and so on. If we can put that hotel service to the ICU and make more, that will earn us some more, income, And some of this income can be plowed to the ICU where we can manage, the indigent patients. So I think that will help us in some way until we find, some other means of, managing the ICU. Thank you.
Thank you very much. Dr. Osman?
Yes, I do not want to say that she was reading my thoughts. But in any case, yes. A practical example that I can readily, recall. The Federal Medical Center here has the VIP ward, and that has the VIP wing and the general wing, and the cost is not the same. So I'm just thinking, is it possible that the VIP or the private ward, where you pay at least 3 times the regular payment for the general population, can have some form of funds, isolated to be able to cater for vulnerable population in the ICU? It's something that they can put in their policy. Okay, because we are charging XYZ more than the normal, so percent should be plowed back into the ICU of the hospital to cater for, those in the vulnerable group. I think that is something, and if that is replicated, across the general hospitals or the teaching hospitals, because most of the ICUs are within the public sector hospitals, I think that would be some local solution for while we're thinking of a long-term, solution coming from government in terms of the NHIA coverage and whatever.
The commissioner for health for 2 times, right?
2 times. I don't know where you heard that.
You're commissioner for health.
Yes, I was.
So when MDs of your hospital, they come to present issues like this, how will you, looking back, how did you tackle those issues? I'm looking forward now. What results can you offer? At least you get on the difficulties. You are a commissioner for health, and I'm sure you had situations where MDs of your state hospitals will come to you to present issues like this to you. How did you manage them? And looking forward, with all the knowledge you've gathered here, how will you have managed it?
Okay, thank you very much. Before I became commissioner, I was also the chief medical director of the hospital management board. So I was also presenting to the commissioner before they began to present to me. What I would say is most of the time there's my advice for anybody going into public service or any form of appointive service is you should first of all predetermine your terms before taking up offer. Every state government has its peculiarity, and then the resources that come to the state is spread across several sectors. What were the challenges? I came to the hospital management. I'd rather talk about that because as a commissioner, there wasn't so much. I spent just 2 years as commissioner for health. And we had, at the Ministry of Health, we instituted a leadership coordination platform for all the agencies and parastatals of health, where we sit down to look at the generic problems of all the agencies, including, critical care, intensive care was not there like that. Yes, but of all the other issues, we discuss the generic issues that cut across board and decide to present them. Now, as a commissioner, yes, you can get all of these, you can present them as EDSCO, and then you can try to lobby your colleagues to put in a word, but there's a limit to, for as long as you're not the governor, there's a limit to what you can do. Yeah. And then we tried as much as possible to institute policies, that can, drive integration of most of the services. But when you talk about intensive care unit as an isolate of all of this, it wasn't one area that we made so much progress.
Final notes, Professor Oshinaike.
Yeah, thank you. Something just occurred to me, and I think it's something that I think we should also think of. And that is making our ICUs semi-autonomous. Currently, I don't know what happens in other ICUs. I know in my own ICUs, we have a director of the ICU, but just a director, I would say. Because when it comes to procurement, dealing with whoever supplies, consumables, the director is not in the know of many things. And I know of another facility in a public hospital in Nigeria.
Mike, what is the problem? Switch. Please check the mic. Take the mic now. Meet them.
I know another facility where the director of the ICU actually is in charge of, has been given the right to decide who supplies, what is needed, what is not needed. In fact, almost everything in the ICU, the person is in charge. What he does is just to render account to the management. And that facility is running very well in a public hospital. So I think if we can, as a department in our institution, talk to our staff, that is if they want to relinquish it. It depends on whoever is in charge, the CMD. When the person was telling me about this, I said, oh, your CMD must be someone who is really interested in results. Because if you're interested in results, you will allow such to work. If you are not interested in proceeds from what you get from what happens in the ICU. So I think this is something we can adopt, where the ICU is semi-autonomous. And with that, because the person in charge knows what he needs, he will deal with. How can you be buying equipment for me? I don't know the supplier. I don't know about the service agreement. In a few years, everything is outdated. You can't service. You have many junks of equipment. So I think that semi-autonomous approach is something we can sell to our management. And I think it can really work. Thank you.
Thank you very much, sir. We are really short of time. So we've come to the end of this panel discussion, and you all agree with me that we've had a robust, fruitful, and beautiful discussion. So on behalf of Mr. President and the members of executives of I-CCSN and also LOC chairman, I want to sincerely appreciate all our panelists for this fruitful deliberation and for your time. Okay. So we have awards of certificate of appreciation to our panelists. So I have the honor of inviting the NSA President, Professor Al-Nati Mohammed, to please help us with the presentation. Thank you.
This is quite unexpected. I've been privileged to present certificates of appreciation to the panelists here. Just to, you should keep it because this discussion has been robust and fruitful. So I want to call Dr. Yakubu Agada Amade on behalf of the I-CCSN, ESCO, and the entire membership. I'd like to present this certificate. The next is my brother here, Professor Babatunde Oshinaike, the immediate past president, am I correct, of the I-CCSN. I present this certificate in appreciation of what you have done today and what you have done before and what you continue to do. Thank you. Next is Dr. Zachary Usman. On behalf of the I-CCSN, ESCO, and the entire membership, I present this certificate of appreciation for being a panelist at this discussion. Thank you. Brigadier General O Adole. I hope I pronounce it correctly. So on behalf of the I-CCSN, I present this certificate of appreciation for participating in this fruitful discussion. Reflections. Really privileged. Next is Dr. or Associate Professor Arinola Shanusi, my mentor. I appreciate you. It's a real privilege. Thank you. She is also, I think, the foundation president. Yes, foundation president. You can see how lucky I am. Thank you. Let me pause correctly.
Your mic is off. The mic is not working. Check.
So Dr. Latishe's certificate of appreciation is a special one. So we'll deliver it to you as soon as possible. Thank you very much. A group photograph, please. A round of applause for all our discussants. The ESCOs, can we have the ESCOs here? Let's take a group photograph at LOC chair.
It's small thing. Don't just assume. Something that's physical, you should show sign that you are assisting.
Sorry, good afternoon, everyone. Good afternoon, please. Good afternoon. I know we're getting tired, getting hungry, but please, we'll give one of our sponsors, Limi Hospital, 10 minutes to talk to us. After which we allow Professor Fatima Farouk in South Africa to talk to us. Farouk is traveling to Hong Kong. He's catching a flight this afternoon. So if you don't allow her, we'll miss that beautiful presentation. So we'll just start with Limi immediately, after which Fatima will speak to us in 45 minutes. We can now go for our lunch. Is that agreed? Thank you. Eva care later on, please, after this. Fatima is traveling now. So already catching the flights. Are you Eva care?
No, wait first. Just wait first.
No, you use my laptop.
No. It's not. There is a presentation. How far with your presentation? You need to talk to them. But they said give me. So that's what I want to know, which one is because your audit says money. So talk to them, let's know which one.
Can we please, Limi, can you start, please?
So there is a Mr. President. You need to set it up. You know the edit panel, just wait a little. That's why I want to call his attention. That
You need to put it on your laptop, on your desktop, because it's now heavy.
Just wait. So wait. Stop. Mr. President,
I take your hand and lead you to the dance floor. It's the music that
put it, no, don't open it, put it on the page. I'll see you. I want to see it.
scream your and say goodbye.
Can just watch from that. Don't worry, just watch from the. It's with them. Pointer, please be the next speaker is on. So raise volume. Then you can turn right. We will give you a tablet if you prefer to use tablets. Or if you want to turn, so on top of the podium. So just be watching, but the next is from your hand. So go on the podium. Climb the podium.
Good afternoon, everyone. Good afternoon, everyone. Perhaps I'll just go ahead. My name is Dr. Iseko. Good afternoon. Can we please just give me a few minutes? I'm about to share something that will be very beneficial to you. All right. Good afternoon, everyone. I'm very happy to be here. This is a very critical society in Nigerian healthcare. I can see some of my teachers, Professor Waso. I can see people from UCH, where I did my postgraduate fellowship, and then ABU, where I did my primary medical degree. My name is Dr. Eseko. I'm an interventional cardiologist from Cardio Care Hospital, which is a member of the Limi Hospitals. Limi Hospital is over 40 years now. Cardio Care celebrated 10 years on Saturday last week, and we are happy to have tried to change the landscape of cardiovascular healthcare in northern Nigeria by the grace of God. I want to show how medicine, surgery, and critical care meet in the heart, and I assure you to be a very good presentation for you. So everybody doesn't need to go abroad anymore, and the cardio care is here. We're happy to be able to talk about that. Now, I'm very happy with the presentation, but I just tell you that money is just the thing that looks as if that's the problem. It's just the tip of the iceberg. What is also problematic is capacity, trust among healthcare professionals, correct diagnosis, and patients identifying their problems. Power is low. So we did a study showing all acute MIs, over 50 patients over a period of time, come with acute MIs that we had interventions done on. By the God's grace, we have done over 2,000 interventions in cardio care. And among those ones, most of the problems were late diagnosis. Almost 95% came later than the acceptable time, 95%. From treatment for ulcer, for treatment for pneumonia. So before we even talk about money, the people that had money didn't have money, did not even know they had a problem. So that to me is the biggest one, and it's below the water level. We are all looking at the money, but we're not looking at the other things. So I'll talk about some of our experience. Number one is in reducing amputation. This is the anterior tibial artery, 10% occluded, which caused that darkening of the foot, almost gangrene. And you can see us putting a stent there in place to try and open up the blockage. And the next image you will see now is after inflating the stent. You can see there's restoration of blood flow. So within 2 weeks, the leg went from that black to this one, and that is a limb saved. When we're in medical school, that will have been an amputation below knee or above knee, depending on the orthopedic surgeon. So these are things that have been available and now available now. I'll talk about this case, endovascular intervention for vascular injury. 56-year-old Jehovah's Witness, referred from tertiary hospital. While dialysis was about to be done, they were trying to cannulate the femoral, and they inadvertently punctured the deep femoral artery. PCV 12%. No blood, will not take blood. So CTSU was not able to do CT was done, and then he was referred accordingly. So this is what we saw, this cardio care hospital. We can see the deep femoral artery, and we can see a small spot of blood where the arrow is showing the area of bleeding. So while we're going to identify that, we are now putting what we call the cover stent endograft. This was just through a needle stick while he's awake, and we're able to stop the bleeding there. PCV post-procedure, so that before, that's after. PCV post-procedure, 12%. And then he was referred back for continued management. All right. So, also, one of the major things we've done, we published this and discussed this at NCS, 3-year data for people with acute PE. I think a lot of us have had massive PE in our ICUs and wondering what we can do. Now, about even last week, I saw a patient 2 days post-surgery with massive PE, saddle embolus, using 10 liters of oxygen, no reflow mask. So what do we do in that case? Most of the cases we're able to do catheter-directed thrombolytic therapy. We get our catheter right to the pulmonary artery. We deliver thrombolytic therapy over 24 to 30 hours. And that patient went off oxygen after 24 hours and was able to go home after 3 days. So this has been, so we had a 3-year experience, which we published. We also delivered a lecture in Senegal for our approach. This same approach was used for a patient. This patient, incidentally, we had put a stent for him 3 years earlier, came with complete renal artery occlusion on one side, his senior colleague, and they had to do the same kind of procedure to restore flow back to that left kidney. So it's something that is available for us. So those massive PE, especially those with hemodynamic compromise, needing unnecessary levels of oxygen, typically they're able to go off oxygen even before the procedure ends, RV function improves, and they're able to go home. So that series has been published. This is an example of that. That's a pulmonary clot that was shown, and this is after the procedure. You can see the flow in the left pulmonary artery quite more, and you see the patient, even while you're on the table, patient is already beginning to show significant improvement. So these are some of the cases. Of course, an IVC filter is typically put for most of those patients. I can see it looks like an APC broom, but it's not in politics. All right, so for cardiac devices, this is a patient that, of course, we can already see the non-sustained VT. Patient with heart failure, reduced ejection fraction, referred for second opinion, and what can we see? Angio was normal. While on the table, he developed what we can see already, and that is a shock being delivered. I kept this picture in case people need to use for exam. So that shock was delivered. Patient came back and started complaining while we're making noise in the cath lab. But afterwards, patient had a cardiac arrest. They did an ICD to prevent a subsequent cardiac arrest. And so an ICD is simply put, it takes about 60 minutes to put an ICD, simple procedure, same way we put a pacemaker, put a lead into the heart, it constantly monitors, and then we put the device in. Yes, it's routinely available every day, any time of the day, and the patient was able to go. Now I'll show you another patient who came in with similar case. No problem. So you can see a patient monitor. This was sent by the medical officer on call. And you can see it changing from the VT, all of a sudden the ICD works and it changed to a sinus reading. So you can see how it changes automatically because the ICD is in situ. Now imagine this person is at home. This is how the person is able to stay alive. So ICDs are invaluable in what is done. And then of course, CRTs. Very important to say that Nigeria is the first to do a conduction system pacing, which was pioneered in Cardio Care Hospital, Abuja, left bundle branch, which is putting a pacemaker, but not just the normal way. Yes, in sub-Saharan, thank you very much. In sub-Saharan Africa, which is not just putting a pacemaker anywhere, is to put the pacemaker along the electrical pathways that God has made. So once you put the pacemaker, the person is able to do that have a pacemaker, but the heart works virtually normally in that regard. Now, when it comes to chest pain and heart attacks, I'll show you a few cases for us to see, and I'll leave all of these because of time. So typically in the cath lab, what do we do? This is a patient, we're able to take through femoral or radial. Nowadays, we use more and more of radial access, and we're able to get our gadgets up to the heart. I still did one. We're able to get that. You can see the narrowing there. That is typical of what's happening. And then we are able to open up a stent and open up the blockage. Now, this is a common procedure. It takes about 30 to 60 minutes to do. Patient's chest pain goes down. They're able to do. And now we're able to have intra-aortic balloon pump to be able to help with patients with almost no blood pressure. I'm sure you can see that very well. I'm told I have to round up. So, but I will show this final case before we I will show one or two cases, one case before we go. Please permit me, sir. I'm trying to gain time. CPR works. CPR works. One of the cases, every year we do a training on BLS. Last year we had over 1,000 healthcare workers that we trained on BLS and ACLS over 2 days. We have a methodology during the Abuja Cardiovascular Symposium. I want to encourage you to send your people there. And one of the centers that we sent people with MOs and nurses, no consultants, were able to deliver 2 shocks, do CPR, resuscitate the patient, and then send. This was something that was very, very impressive, and we're very happy about that. And when the patient came in, this is what the symposium looks like. And when the patient came in, they had an MI, of course, and were able to open it up. This is one of the years. This year will be in our 10th symposium, and we are very happy to invite the I-CCSN so that they can be part of it and see how we're able to empower primary health providers to be able to deliver life-saving care across board. As I round up, I want to show in the cath lab, this is an expected with an inferior MI, and we can see that there's a 100% occlusion of the distal RC. The RC is supposed to form a very big C,
but there's 100% occlusion. By the time we cross this clot here, the next thing that happens is severe bradycardia, heart rate of 25 per minute. So what do we do next in that kind of situation? We put a temporary pacemaker. I think you can see that wire going in. Put that one quickly within 3 minutes. Heart rate comes up. But the next thing that happens, he had a VFib. Deliver the shock, and then we are able to complete the case. So these are the simple cases that are done regularly every day here. And by God's grace, we're able to do postgraduate training, and we're able to train most of Nigeria's senior registrars. So we have MOEs with UCH, OAU, IFE, UPTH, University of Abuja, FMC Jabi, FMC Katsina, FTH, and the list goes on. So we are able to provide this service for all over. Now we talk about money. It's not particularly cheap. So we also still offer 10% of our annual procedures for charity purposes in conjunction with donor agencies. Thank you very much. So finally, I will just say that cardiac surgery is now available for us all day, every day. No longer wait for people to come once in a month. No, every day. You have a case today. We've done CABG, we've done aortic dissections, we've done valve replacements. Any day, adult, pediatric, we can do it just like we're able to do interventions. We've been working on this for 4 years, and I'm very happy to announce that it's now available for us regularly. Thank you very much for having me. I'm very grateful to be here. And my team are around. They're passing out some papers, so you can actually just join up. Thank you. My contacts are on the screen. The contacts are on the screen in case you need to reach to me for any other questions or to be able to answer, to be able to have your referral sent. Or we can just discuss cases, and I can show you how we can assist in critical care across the country just via WhatsApp. Thank you so much for having me. Any questions? No questions. No questions. Okay.
Are we taking? Who are we taking?
Next, AMC. AMC. If AMC is not ready, please come. Please come. We don't want everybody to be in front. Please, you can come and go ahead.
Which one? Who is presenting? What is your company? You sent it. Did you send it as right? Where is it here? What's up now? It's already coming by WhatsApp.
But who's presenting? Me. No, you drink. No, not drink. No. Guys. Please, after we. Why is traveling if you won't go? Is that MC? Yes. Drink and you are guy. Do you have my size? Why? Sorry?
Come in, let me just project this because we're. Let me just project one thing, sorry.
Go ahead, your time has started.
We are waiting for the presentation. Okay, good afternoon, ladies and gentlemen. My name is Kehinde Oyeshiku. I'm the Director of Business Development at the African Medical Center of Excellence here in Abuja. It's a pleasure to be here today. I just want to take a few minutes to introduce the African Medical Center of Excellence, AMCE, to you, and to tell you about a little bit about what AMC is doing. It's not going. Okay. So the AMCE, African Medical Center of Excellence, is a 170-bed tertiary hospital developed by Afrexim Bank, Africa Export-Import Bank, in partnership with King's College Hospital in London. The AMCE started last year. We were launched in June 2025, highly focused on non-communicable diseases, specifically 3 non-communicable diseases:
which is oncology, cardiovascular services, and hematology, with supporting services in general medical and surgical services. The reason why AMC was established, several reasons, but I will emphasize two. One of it was to reduce medical tourism, therefore providing the services that people go out of the country for. And the second reason was to stem brain drain somewhat, at least to a certain level, because people are not always going out just for financial reasons, but also because they don't have the kind of maybe infrastructure that they would like to work with. Okay, so the reversal of medical tourism and to also for healthcare migration. They say I have 2 minutes, so I'll be very fast. So I'll just tell you a little bit about our infrastructure and our services. So for every medical specialty that we offer services at the highest level of care. So in oncology, we provide end-to-end from surgical oncology to radiation oncology to chemotherapy. So we have 2 linear accelerators. We have a brachytherapy to cover oncology. In hematology, we do we started stem cell transplants. So we've done stem cell transplants for multiple myeloma. We've done some successful cases. They've been discharged. We're planning stem cell transplants for sickle cell in August, and we're working off the patients already. In cardiovascular services, we offer interventional cardiology as well as cardiac surgeries, open heart surgeries. And we've done some surgeries, including aortic dissection. In general medical services, we offer from wellness checks to several, diagnostic services in advanced diagnostic services and imaging department. In oncology, I have to state again that we recently did the stereotactic body radiation therapy, the first of its kind in the West African region, where high dose radiation is targeted at tumors, for example, in the lungs. So we've started that already, and we've done a few procedures with that. In terms of infrastructure and technology, we have 5 operating rooms. We have a 20-bed ICU. We have 3 cath labs. We have our own PET scan. A lot of people have been asking us about our PET scans. Our PET scan is expected to start in about a month. The only reason why we've not started is because we're waiting for some quality clearance. And, once that is done, then our PET scan will start serving, the populace. We have a 3 Tesla MRI, the only 3 Tesla MRI in the region, and several others, SPECT CT, a very, very comprehensive, fully automated laboratory, and all that. That is just to provide some context. The reason why we're here is to not just introduce the center, but also let you all know that we are here to work with you. We cannot do it alone. There's a lot of great work already going on. I listened to Dr. Iseko's presentation, a lot of work already going on, fantastic work already going on. But at the end of the day, we need to work together collaboratively to really ensure that the patients get the best outcomes. They're rushing me, but I'll tell you our value proposition. We have a state-of-the-art center. We have very highly skilled and highly trained personnel. So it's not just about having a beautiful center that is equipped with the state-of-the-art technology, but you'll have to have the right people. And I can tell you that at AMC, we have the right people. Some of them are here, seated here. We have the right people, a very good mix of the best local talents that we have, plus some international talents as well. And in terms of services, we have services that typically people would have gone abroad for is now available for you locally here. Not just curative, also diagnostic. We have them here. For example, in our lab, we can do a lot of tests that currently go out of the country Of course, when you are doing those tests locally, turnaround time is faster and the doctors can make decisions faster. So that's also a good thing for us here. We're accessible. People would say, yes, maybe it's expensive, but we think that it is competitive, and we know that going abroad is more expensive. So we say that we're accessible. We offer patient-centered care. We're focused on the patient. We take feedback very seriously, and we ensure that our patients go away very happy, recommending AMC wherever they go. And of course, we have clinical partnership with King's College London. What we're trying to do with King's College is, just continually ensure that we're on top of current realities, current trends, and making sure that quality assurance is top-notch. I would just say here that, we have very great plans at AMC, very, very grand plans, which includes even setting up a medical school and a nursing school, yes. And these plans are going to come to fruition. And very soon, we're also starting our training. We're going to start residency trainings. We're going to start training certifications, So it's something that training and development is also a key part of our offering. A research center is also being built. We're going to start clinical trials. We already have several big pharmas and several big organizations that are partnering with us for clinical trials. We cannot do those things alone. We still need you. And so we're going to be reaching out to a lot of organizations here to support us and to join us with clinical trials and research. So this is just a bit of our management team and our clinical directors. Thank you very much. Sorry?
Thank you very much, AMC. Evercare, please, over to you.
He gave me like 3 minutes. 3 minutes.
1 minute, let me upload it first. The pointer is on the stage. Can you press when I share?
Just start doing introduction. Let's before the slide comes.
Press the pointer, left, right, let's good. Home from beginning, left. Good.
Good afternoon. Starting on the existing protocol, I'm Kayode Opadola. I'm a consultant intensivist with Evercare. So I'll be taking us through briefly about Evercare, and most importantly, telling you about the critical care unit of the Evercare hospital. So I'd like to tell you that Evercare is one of the regional hospitals located at Lekki Phase 1, Lagos, and is the African part of a group of hospitals. It's a 65-bedded hospital with 39 critical care beds, comprising of the adult ICU, the neonatal, and the pediatric with a coronary care unit. Okay. So we are patient-centered, but the mission here is to deliver timely and evidence-based multidisciplinary care that improves survival, restores function, and delivers that exceptional service that we are all yearning for and we are working towards. The vision of the hospital is to be that center recognized in Nigeria as the hub for the West African sub-region. So the ICU, which I'm talking about, is at the center of all these other connecting parts to care for our patients. And that's the picture of emergency unit with the emergency team right there. So the adult ICU has 22 beds with 4 negative pressure isolation units and is consultant-led 24 hours all through. We have medical officers, we have highly trained nurses, ICU nurses who work together to deliver that care, and these are the various capabilities of the unit. So Our clinical capabilities range from respiratory support, cardiovascular support, neurological, and we also manage sepsis. It's one good thing to know that in Evercare, the ICU has all its capabilities. We don't take our patients out to do dialysis or do something as basic as chest X-ray. All these things are done at bedside. And most times we pride ourselves in that we have even MRI compatible respiratory support. This is about the only center in Lagos that has that. So, care starts right from the emergency point. You can even call the Evercare ambulance service to pick you from home, which we've done several times. And once you are dedicated to have HDU or ICU care, you don't waste your time at the ER. You have moved straight. The team is well grounded to receive you once you are coming in with any patients. So this is how we connect the patients. Everybody is put on spots. They are all involved, all the specialists, to care for that patient till discharged. And so building capacity, like what we are doing here, we've been here, sponsored by the hospital to be here to learn from all that has been presented. And even in-house, there's still continuous training, simulations. Last Saturday, the general surgeon still took the medical team on chest tube insertion, which was a very lovely training course. We still have house officers coming in. Yearly, the hospital trains 10 house officers. Nurse interns are also under our training every year. Starting from November, we have intakes. Now, we collaborate with other sister organizations, hospitals, even LUT, ICU training school. They have their students coming to us for hands-on skills acquisition. So technology is needed and is the bane of what we also share with people. We have all these advantage of from our radiological suits to the cardiology unit. So, like I said earlier, specialized services are ongoing. We've had costs to manage both black and white, and they've given feedbacks which we want to build on. So the quality and patient safety, we don't take that for granted. So we go through all these safety bundles and ensure that quality improvement goes on with clinical audits, root cause analysis are done almost on a daily basis. So this is how we go through the framework for clinical governance. So this just to show our research, we are also into research and we are looking into the future to ensure that we digitalize so that we can reach out as much as possible and collaborate with other sister units. Artificial intelligence and tele-ICU is work in progress for us, and we are not taking that lightly. Very, very soon you will hear that Evercare is doing tele-ICU. Thank you so much. We have been rushed. Hi.
Hi, good afternoon. Oh, I'm starting on all the existing protocol. Before we go for lunch, I want to call on one of our speakers, all the way from South Africa, is going to be joining us online. She's an erudite intensivist by the name Professor Fatima Farouk. Sorry if I made a mistake with the pronunciation. She's one of the African distinguished critical care physician and a prominent advocate for the advancement of intensive care medicine across low and middle income countries. She's full professor and clinical academic head of the Department of Critical Care at Steve Biko Academic Hospital at the University of Pretoria, South Africa. Professor Farouk made history as the first female president of the Critical Care Society of Southern Africa, a milestone that underscores her leadership and influence in African healthcare. Over the past 2 decades, she has played a major role in strengthening critical care education, training, and research throughout the continent. Our research interest encompasses sepsis, antimicrobial stewardship, tele-intensive care, HIV-related critical care illness, obstetric critical care, trauma, medical ethics, and post-ICU outcome. She has contributed extensively to both regional and international research collaboration aimed at improving outcome for critically ill patients in resource-limited settings like ours. Professor Farouk has delivered hundreds of invited lectures at major scientific conferences worldwide and has served in leadership positions within the World Federation of Societies of Intensive and Critical Care Medicine. She currently serves as treasurer of the Federation and remains an influential voice in global critical care policy, education, and research. Her commitment to excellence, mentorship, and equitable healthcare delivery has earned her international respect as one of the leading female figures in contemporary critical care medicine. Please join me in welcoming Professor Farouk. Thank you.
Thank you, Mr. Chairman, for that very kind introduction. It really is a pleasure to join your prestigious meeting. Good afternoon, everyone. A word of thanks to Dr. Otokwala, the president of the Nigerian Critical Care Society, for this invitation and for putting together a very successful meeting. Today, I'm going to share with you why it is so important for us to make our critical care data visible to ourselves as clinicians, to our managers, to our policymakers, and the community that we serve, our patients. And in essence, what I'm going to do is cover why ICU data is so important to us, what a good set of data looks like, what we should consider measuring, what we should interpret with caution, what we can achieve with registries, and how you and I, in resource-constrained environments, can consider data collection. I have no real disclosures for this presentation. So for us as healthcare practitioners in the critical care space on the African continent, indeed, work life is tough. We really have to make very tough decisions, but we always adapt, we innovate, and we get there trying to make the best possible difference we can for our patients. But if somebody were to ask us, how is your unit doing? How is your unit performing? How many of us can objectively answer this question? Can we say with certainty that over the last 5 years, our ICU has become more safe, or the mortality has definitely improved, or that our antimicrobial stewardship program is working, or that when we make triage decisions, we are using our resources as wisely as we can? And the truth is that unless we have concrete data, we really can't answer these questions about our performances accurately. It is true that we face a lot of resource constraints, be it in the domain of electricity shortages, oxygen shortages, internet connectivity, or the real structural tools of our trade, ICU beds, having clinicians trained in critical care, nurses trained in critical care, essential drugs and equipment. But the reality is that this should not make us stop from trying to get data. And the reason is, if we look at situations where the resources are abundant, when practices, clinical practices are inefficient, this may translate into wasteful expenditure. But when we have resource constraints, like we have on the African continent, when we are efficient, this can be hugely problematic. Imagine if we have 3 patients who are trying to bid for 1 ICU bed. If our decision is ill-informed and we give the wrong patient the choice of that bed, we can end up with 3 deaths as opposed to possibly 2. So when in the face of scarcity, quality assessment actually becomes even more necessary. If you and I walk into an AGM of a business, at the bare minimum, we would expect a balance sheet. We'd want to know what the assets are, the expenditure, the risks the company is facing, the performance, what is their return on their investment, what are the threats they're facing, and what's their turnaround strategy. And in a similar vein, in the critical care space, the data that should be available is our essential balance sheet. I don't think it's our fault that to date we have not managed to place so much emphasis on data. And the reason is when we have been trained, undergraduate or postgraduate, the emphasis has always been on patient care, improving survival of patients. It's not really focused on how do you adjudge your performance, how do you adjudge your return on investment, which really is so important in the context of critical care, which consumes so much of our resources. When we have inefficiencies, unfortunately, if we don't collect data, they remain invisible. Take the example of you doing a ward round tomorrow morning and finding that a patient who arrived at midnight only received their first antibiotic dose 6 hours later, despite being in septic shock. Understandably, you would be angry, you would speak to the appropriate individuals, but you would probably put it down as an isolated event and hope that it would not recur. But if one had a database, one would actually be able to explore whether whether this happens recurrently at night or over weekends. Is there a pattern? Who does it affect? Does it affect only individuals who are being managed at night? What is the consequence? Do these patients stay longer? Do they have greater morbidities? And without all this information, one really cannot advocate for more pervasive change in our clinical practices. So if we look at the context of having a data repository or a registry as opposed to research and the audits that we are far more familiar with, when we do research, we're really asking one or a few questions about whether something is the right thing to do. For example, what is the most appropriate timeline for antimicrobial therapy to be given in a patient with sepsis or septic shock? And when we find that answer, we can do an audit to see over a predefined duration whether we actually are achieving it. Having a data repository or registry takes it even further, because now you can see for yourself if the right thing is being done consistently for the right patients. We can dive into patterns, consequences, we can advocate for change, and we can implement change and subsequently adjudge the response to intervention. And I really would like to emphasize that having a registry is not about identifying a wrongdoing. It's not about victimization. It really is about getting a greater understanding of the system, the gaps in the system, so that we can constructively address them. But fundamentally important is to have buy-in by the entire team and a belief that the data does matter. And if one has a registry, one really can have institutional memory and can have the ability to implement ongoing quality improvement. What is fantastic about having a registry is we can actually explore relationships and links between what we have and what we do in terms of the outcomes that we achieve. So we can look at whether poor outcomes are, for example, related to a lack of staffing or a lack of protocols, or if a lack of protocol is related to a lack of a mobilizing program, which then impacts on duration of stay. And these kinds of relationships and signals are of paramount import when they emerge from a registry. What truly makes data valuable is not just having it. Having it doesn't make a material difference in the outcome of our patients' lives. What truly makes it valuable is when we can actually implement a change and drive change towards positivity. Of course, it's of paramount import that the data we collect is reliable. The definitions of what we collect are shared, because remember, when we're looking at registries, we're not looking at an isolated ICU. Ideally, we want a registry in a country. We want registry within a hospital, and all the ICUs should ideally be on board. And we really want that data to reflect the reality of what is happening at the coalface, so it's trustable data. So when we talk about the quality improvement loop, having the data is just the starting point for that quality improvement exercise. It really is about collecting the data, having dashboards, analyzing it, looking at the signals that emerge. Very importantly, providing feedback to clinicians so we can get buy-in and advocate for changes in practice and subsequent re-evaluation. Registries are truly important because not only do they identify gaps, but they help us to advocate for policy change. They help us to advocate for funding. Especially nowadays with our economies being so tough, we do need to get funding, not only from our own hospitals, but from the private sector, from countries outside of ourselves. And if we have data, we really can advocate for funding. And of course, it can stimulate research so that we practice translational research. A huge advantage of registries is to allow benchmarking, comparing our performance with the performance of the ICU next door in our hospital, or the ICU a few blocks away, or in our country, or even on a global scale. And what I'd really like to emphasize is that when we're looking at benchmarking, it's not about being judgmental. It really is when we to find out if we are not performing suboptimally, to garner insights into why that performance is suboptimal. Surely, if we compare our outcomes to a high-income country, we don't expect our mortalities to be on par. But that does not mean that we are performing subpar. It really might be a reflection of the context we work in, because it might, remember, when we look at risk-adjusted mortalities, they don't take into context the situation we work in, the constraints we work in, the resource constraints, staff constraints. So when we look at benchmarking, we also need to appreciate the limitations of risk-adjusted mortality and the context we are working within. So how do you and I shift that paradigm so that we can really make our data visible in our environments. There certainly are a huge number of opportunities to do so, but we do need to be cognizant about the realities we face. Our workforce capacity is often very small or subpar. We work in very siloed systems. We have a very unique burden of illness. I think the vast majority of us are still paper-based, and it's going to be a long while before we become electronic-based. We're always working under pressure, and most of our time is spent on service delivery rather than research and administration. We have real problems like electricity problems and internet connectivity. And the one thing that we, I think, do suffer from is the culture, a lack of a culture of feedback, which is totally important if we are going to advocate for change. And then, of course, there's always skepticism around registries. There's a question about who's going to produce this data, who's going to own it, and who is going to benefit from it. But the truth is, you and I can't wait for all these problems to be solved before we can implement or start a registry. And indeed, there are some very successful and very mature registries that have emerged from resource-constrained environments. Many of them have a very huge success story. But what you can know, what is very clear is they've all started small and gradually built up. They started with a small, disciplined data set, and integral to their success has been having clinician buy-in, agreed upon definitions, a minimum data set, but one that is meaningful to the local environment and is actionable. There's no point in exploring variables that we can't change. So we really need to look for what the low-hanging fruit in our environment would be. And of course, integral is that these successful registries have also been successful because of regular feedback to the teams. And it's quite nice to see that if you look at the very successful registries around the globe, they emanate both from the high-income countries and a fair number also from low-middle-income countries. Of course, I think the most robust amongst the high-income countries are the ANZICS database and the UK database. But certainly the South American databases, the ones from Asia, are certainly quite robust, and it's good to see Ethiopia on the map as well. What is evident when we look at these registries from around the globe, the data sets are quite heterogeneous, and it's not surprising because depending where in the world we practice, our admission thresholds, our diagnostics, coding, comorbidities because of the case mix, our treatment strategies and options, staffing, and the medico-legal framework all influence our data set. And therefore, it's important for us when we devise our own data sets not to look at the best data set in the world and say, let's mirror it on that. We really need to create a recipe for our own individual environments. What is a common theme or objective for these registries is quite common, in the main being quality improvement, gauging epidemiology, surveying diseases and other parameters, evaluating policies, gaining insights on from benchmarking, and even using these data sets for research. This is a very nice paper that was published in Critical Care Science very, very recently. And this was an attempt to see or to get a register of all the data registries around the world, all the countries involved. And it's good to see some green on the African continent, but in the same vein, I'd also like to see there's not enough green all around the world. And indeed, what they found was that only 1 in 5 countries around the globe actually have an active registry, and the resources to support these registries are very variable, but they all emphasize on quality improvement. Their data collection methods often vary. The content of their data sets vary. They often use predictive models that vary, and this is not surprising. When we use a predictive model for outcome, we really need to validate it in one population. So it's no surprise that different countries either develop their own predictive models or validate them before they utilize them. And indeed, in terms of barriers, they find that legal constructs within which clinician works can become a barrier. They also pointed out in the paper that there's an insufficient use of the data as a platform for research, and this can be built even further. I thought I'd share this link of the Logic initiative with yourselves. Essentially, what the Logic initiative relates to is linking global ICU registries from around the world. The thinking behind Logic is to pool global data in an anonymized way so we can have a global registry of critical care. And this is basically to compare epidemiology, look at patterns of illnesses, benchmark, understand differences around the world, and get some learning points from the data. The last time I checked, the 13 countries were on board with more than 150 ICUs, and this included more than 7 million ICU patients. And I was very fortunate a few years ago to attend one of the Logic meetings, and it truly was a heartwarming experience to see particularly individuals from low middle income countries coming and talking about the success stories of how they've built their registries into very mature data sets. The Logic initiative really looks at very simple parameters like number of patients, ICU beds, mortality rates, length of stay, and organ support. And it's something that I think that's really worth considering. I thought I'd chat a little bit about this paper that was published by our Ethiopian colleagues recently and some of the lessons that they've garnered from their journey in developing a registry. They are still in their infancy. They have brought about the creation of the registry through funding through the Critical Care Africa Network. And how they do it is they have trained data capturers supported by this network, and they use tablets and a cloud-based storage. Some of the key messages that have emerged from their first paper on this registry is that we really, on the African continent, need to look at offline data collection solutions as well, because internet connectivity can be a huge problem. The importance of communication is highlighted, in particular, having buy-in from the clinicians on the floor. A data registry is really successful when there is complete buy-in. Sustainability is a concern, bearing in mind that this registry is supported through funding. Funding is never guaranteed. There were questions raised related to concerns around ownership by some of the clinicians. So that is something that needs to be clear and articulated to one's clinicians upfront. And of course, the importance of training when one initiates a data registry. From a South African perspective, we too are very much in our infancy when it comes to registries. Our journey only started about 3 or 4 years ago, and it is also supported by the Critical Care Africa network. The method is very similar to the one adopted by the Ethiopian colleagues. We initially started with one site, and it's only now that we have 3 sites on board, and we're looking at boarding more sites. What we have done is we have done it under the auspices of our Critical Care Society, and we've also included through the society a governance structure to oversee the rollout and implementation. And as I said, we're still very much in our infancy at the moment. I came across this paper from Nigeria, and it was also very heartwarming to see that the Intensive and Critical Care Society of Nigeria is supporting a national ICU registry in Nigeria. So when it comes to choosing indicators, I think this is one of the most important steps where one needs to be very careful, because everything about one's success on a registry hinges on the choice of indicators. And really, it shouldn't be about quantity, it should be rather quality. And the indicators that one chooses really should reflect the local burden and the local opportunities so that one can really implement change. The data that one considers should be such that it can be reliably collected, meaningfully interpreted, and realistically improvable. And it's always good to start with a minimal practical data set and grow as one's confidence improves and the data set matures. This is by no means meant to be a menu to pick from, but suffice to say that the parameters that one looks at really emanates from these 5 domains: your patient admission profile, the age, the comorbidities, whether it's an emergency or an elective admission, your severity of illness, the level of support for organs. Are you using vasopressors, mechanical ventilation, renal replacement therapy? Something that's very important for our databases would be, of course, the availability of resources, our staffing ratios, what equipment is available, what's not available, the delays that occur, the administrative delays that happen, and so forth. And of course, last but not least, your outcome parameters, be it pressure injuries, mortality, nosocomial infections, and readmissions. So what would be a practical roadmap for implementation and growth? I think at the outset, it would be important to define one's purpose of creating that registry. Is it to improve care? Is it to improve capacity? Is it to garner support, change policy? Or is it at this point surveillance? And it could be all 5, or it could be 1 or 2 at a time with subsequent growth. The minimal data set and collection method needs to be decided and agreed upon. For me, it's paramount that there is some governance. So there should be some terms of reference in terms of ownership, privacy, access, quality checks, so that there is oversight and the transition is smooth. Ideally, one should plan an initial pilot, and with some monthly feedback, so that one can identify the gaps and improve on them before one implements the second phase of their rollout. And ideally, finding 1 or 2 signals at most and see what action one can take to improve and measure the level of improvement. So I am going to wrap up, and what I really want to share with you is that having data in critical care is really about building a fairer critical care economy. And the data that we collect should really be meaningful, trusted, and be linked to action. Thank you for your attention.
Thank you very much, Prof, for the wonderful presentation. We really appreciate your presentation. And I believe that a lot of us has picked a lot of information from this, your presentation. As you rightly said, data in critical care is still one area where we are still battling with. And I believe this, your presentation, will be an eye-opener for all of us on need to actually emphasize on data collection, which can go a long way in improving the quality of care for our patients. So I'm going to allow questions from the audience. Please stay with us to entertain some of these questions. We also work on sending them to you after this. So I will call on us to ask our questions. So let's ask our questions. Please, we can come forward with our questions if we have any.
Mr. President.
Okay, I will allow Mr. President to talk.
Okay. So now you can.
Farouk, thank you very much. Thank you for that excellent lecture that you delivered. I think one comment I want to make is that it's extremely important for every local ICU to have a data. You have ICU registry in every ICU, and then collectively every region, every province, and then the country as a whole. In Nigeria, we are trying to do one at Lagos and Ibadan, but we've not submitted those entries and then we publish them for you to have access to them. But we think that South Africa can actually assist us since you've done yours. It tried to stimulate us to have a collective country-based registry, so that people out there would know that we also have ICUs here, and we're also collecting data, and then that would tell the efforts we are making either to ensure quality improvement in our practices. So the only question we have is, how do you assist us since you've done yours?
How do I
assist Nigeria? Because we have only 2 centers that are involved in collecting data. We have 2 centers that are adopting this country-based, center-based registry. We don't have a country-based registry. We have only 2 centers, University of Lagos Teaching Hospital and Basic College Hospital in Ibadan. But
so we are in the same boat as you are. We only have 2 centers. We only had 1 center collecting data 3 years ago. That then grew to another center, and it's only like last week our 3rd center came on board. So it's not an easy journey to get from 1 center to 3 centers. So we are not a country registry at all as well. And I think part of it has been the logistics of setting up a registry. That is the biggest problem I think we all face. And I think that's where we can on the African continent reach out to organizations like Critical Care Africa Network to see how can we work together, how can we get your support, because the truth is we are in tough economic times and they're getting even tougher, and data registries need support. I mean, they don't happen just like that. I mean, if we want a proper registry, so for us, it's taken us, it was only 1 center, 1 hospital that started 3 years ago. Then it was 2 hospitals, I think 2 years ago, and now the 3rd hospital. So, and I mean, we have so many hospitals, so it's like a drop in the ocean for us as well. Ethiopia, I think it's just 2 hospitals as well. But I think considering all the resources constraints we have, we are all doing remarkably well. I mean, we want to make a difference. But I think initiatives like support from Critical Care Africa, network support, I can put you in touch as well with, we have a governance committee in our society, and we've put one particular individual, David Thompson, in charge of registries. And perhaps we can have a meeting and see how, learn from one another as well, because I mean, that's the only way we can learn from you and you can learn from us in terms of how we can navigate the space better.
Thank you very much. Thank you. So I want to use the opportunity to thank you again. Sorry for keeping you, and I know you were traveling.
Not at all.
But you've done extremely well. We are still keeping in touch. Don't forget the ICU World Round we talked about at Vancouver. So
Yes.
we will go, discuss with your local president and then get across to us. So what they humbly called our former president and council member, I'm sure you know, Professor Bashino Ogumbiyi, to present a little token to you in form of a plaque. Prof, thank you.
Thank you so much, Dr.
We'll give it to you in India or somewhere else that we'll meet. We'll send the e-copy to you, but we'll give it to you physically when we meet in India, God willing.
Dear Professor Fatima Farouk, thank you so very much for your very insightful lecture to us this afternoon on data sets in the ICU setting. If there is one word or one statement which I want to take away from this, your lecture, and that's not to just collect data in the ICU, but to collect data which aims at improving our patient care. I heard that, I noted it, and I think that's very, very important. When our president, Dr. Job Otokwala, asked me to present this to you, this plaque, in appreciation for serving as one of our distinguished keynote speakers, I did not hesitate to do this honor for you because I know that you are in South Africa and I happen to practice in Namibia. We are just neighbors. It will take me less than 1.5 hours or thereabouts to get to bring this to you in South Africa. That's one. Secondly, I want to congratulate you as the current treasurer of the World Federation of Intensive and Critical Care. We met in Vancouver last year, and also we have a thread in common there. I was a member of the council between 2017 and 2021. And I remember very well that it took quite a while for my colleagues, my friends in South Africa to join us on the council. And thirdly, it's indeed a pleasure for me today to make this presentation. And I believe you are listening to us. Professor?
Yes, I got dropped off, but I rejoined.
Oh, all right. Yes, so it's indeed a pleasure for me to make this presentation to you. As I said earlier on, I practice in Namibia, which is just next door to you in South Africa there. So it will take me less time to bring this physically to you in South Africa than for Dr. Job Otokwala to take this to you in South Africa. So thank you so very much. And so on behalf of the Intensive and Critical Care Society of Nigeria, I want to present this award of appreciation to you for serving as a distinguished keynote speaker at our 11th scientific conference in Abuja here for this good year. Thank you so very much. You'll get the physical award when we meet in India.
Or wherever in the world.
Yes.
Thank you so much. I do appreciate it.
Yes, thank you. Dr. Job, I think Dr. Job should take this on your behalf. Yes, somebody has to take this on your behalf. All right.
Applause for her.
Thank you very much, sir. Thank you very much. So, thank you very much for your time and patience so far. I want us to go for lunch now so that all the members of the Intensive and Critical Care Society can gather afterward for our annual general meeting.
No, we have product presentation, products before AGM. So once you come
Okay, so immediately after lunch, let's converge. We still have some product presentation before we go into the AGM. Thank you very much.
Fair on me, girl, I stay with you. My nigga, go on.
I'm going to be calling on the Mindray representative to talk to us about the new innovations that the Mindray want to discuss with us. Please let us sit down and listen. Thank you.
Good afternoon, everyone. Pleasure to be here again, to be with you. So my name is Dr. Gerard from Mindray, covering the African region and Middle East. So today I will take you through our innovation in designing your smart ICU. Yes.
Just press next.
I'll give you 2 minutes.
Okay. It's not working.
Just press forward once.
Okay, so I'm speaking on behalf of CHMS, Crown Healthcare, who's our representative for Total Solution in Nigeria here. So as we know that Mindray manufactures different devices, we see that it's not just ICU, but OR, emergency, lab, and imaging. We do that. And these are now our ICU solutions, from ventilation to monitors, ECG, and the FIPS. And let me see how we can help you design your smart ICU here. So when it comes to mechanical ventilation, from the transport ones to the advanced SV700, 900, this is our new solution, and you'll see how it can really support you in your ICU here. So it's been labeled Inspire Every Decision, because we know that you have to make a lot of decisions, and every decision matters when it comes to the outcome. So we know that now we have, more requirements from the patients. We need to ensure precise clinical diagnosis, and we need more considerate care taking and more efficient information management, because we have a lot of information in the hospital, which is really underutilized. So now let's see how we can inspire your decision. So first, we can inspire your clinical decision and management decision. Let's start with clinical decision. So we know that when you are ventilating our patient, we need to think about lung protection ventilation and how can we implement that. And the patient may fight the ventilator, so how to ensure patient ventilator synchronization, and how can we know if it's the right time to wean our patient, and what about the sequential treatment. So let's see how the machine can support you.
First, we know that the machine can cause VILI, and we know that VILI will cause, increased length of stay and even mortality. So what solution we've got here? We have the conventional tools, like to set your ideal body, the tidal volume, you rely on the ideal body weight. And also we have the PV tool to guide your PEEP titration. And if the patient is not making it, you can do recruitment maneuvers using the ventilator. But apart from the conventional tools here, now we've added more, and which are even better for your academic purposes. So we have driving pressure here, which will be automatically displayed, and stress index. And if you deal with the neonates or a pediatric patient, we've got this parameter, C20/C, to know if you are causing overdistension of the patient's lungs. And this is now new mechanical power. It will also automatically be calculated. Why do we care about mechanical power? When we talk about lung injury, we talk about volutrauma, barotrauma, but we usually don't care about respiratory rate. But respiratory rate is very important because imagine if you are punching me per minute. If you punch me 10 times or you punch me 20 times, the injury will not be the same. So mechanical power takes into consideration all the parameters, and it will display a value on the machine. And we've got this Palmosite Pro, which is very intuitive. Look at this ventilator. Now you can see the volume you are giving. It is 6.9, which means between 6 and 8. You can see that we are giving less than 30.
Why?
You can also you can also have the driving pressure here, and the mechanical power also will be displayed. Maybe the issue is what value is normal for mechanical power, because we don't have guidelines. So now we don't have guidelines, but there are many studies showing that if it's less than 17 joules per minute, that's a good one. But I believe through studies, guidelines will follow. So this is how it looks. And when the patient is on non-invasive ventilation, you can set a support pressure of 8 or 10, and you ask yourself, I'm giving a pressure of 10. Am I over assisting the patient or under assisting the patient? So now we have the P muscle, which is the respiratory, muscle pressure. So here the machine can give you that parameter, and it tells you about the patient breathing effort. The good news is that you don't need any catheter. It's not never that you need a catheter. You don't need esophageal pressure monitoring with the esophageal catheter. So, and you don't need to use any occlusion. So it's gonna be accessory free, and you don't need to do anything. The parameter will be just displayed on the screen. So now you can know if I'm giving a support pressure of 10, am I over assisting or under assisting the patient? I can say this is a very new concept because no other manufacturer can have such a parameter without any additional catheter, which may be invasive that way. So, and now when it comes to patient ventilator asynchrony, very important, because you see, now you are here in this conference. If you have a patient in the hospital, most of the time, nurses are dealing with the patients. And to know about asynchronies, you need to analyze the waveforms, which is a bit complicated. So now we've came up with an algorithm which can assess all the asynchronies. Let's see how it works here. So the machine can analyze the waveforms and tell you there's a patient ventilator asynchrony and which type of asynchrony you have. Maybe it is, ineffective effort, means you need to increase the flow, the trigger threshold, or you're having double triggering or flow starvation. You will have an assessment and you don't need to do anything. The machine can analyze all the waveforms and give you that parameter. You see here we've got the asynchrony index. So here the machine have AI, like asynchrony index percentage. We've got the number here. So the machine will analyze the waveforms and tell you in the last half an hour, you've got asynchronies in 24% of the time. And the most common asynchronies is maybe ineffective effort. So you should do this and do that. So this is very interesting, especially for nurses when you are not around. So then you can be like, how can I trust what this algorithm is doing for me? We validated the data. The accuracy is over 90%. And for smart ventilation, you've got also this mode AMV, automatic, where you just set 3 parameters, FiO2 and the PEEP and the minute percentage, and then you can ventilate your patient. Yes, so now in summary, you see that here we've got an algorithm which can improve synchronization for your patient, and then the machine will tell you what you should do. And we know that also pneumonia can harm your patient, and in order to reduce the risk of VAP, you need to reduce the ventilation time. So we've got a winning assessment tool. This is also something new. Because our ventilator and the monitors can be connected to the central system, the ventilator will get information from the monitor, and then it can decide, since I see the respiratory rate is like this, SpO2 like this, now let me assess for you the chance of winning successfully the patient. So apart from these RSBI, NIF, and P0.1, which are conventional, now we've got this, winning assessment. So the machine can get the data from the patient monitor via central station, and then you have ventilator data. And if you do ABG, input the ABG result manually. Now the machine will use the algorithm and tell you, if you extubate this patient, you have 80% chance of making it, or 80% of the time this patient not to make it if you extubate them. So this is how it looks like. We've used different database, even some global database here. So the machine can tell you the chance of successful winning is high or low. And it's because we have all these factors, positive and negative. By assessing all of these factors, the machine can give you the probability. Yes, and of course, we have also the SBT that you can use on the ventilator. So after extubation, you're like, let me give high flow to my patient. How to know if the high flow is working? Now we've got this HFNC side. We will get the ROX index. So we see the green area, which is a good sign. So you can see the trend here. If the trend is within the red line, it means the high flow is more likely to fail. And if it is this transitional time, maybe you need to increase the flow or the FiO2. So this good because we don't want also to waste too much time giving a therapy which is not working. Okay. And this is, look at this. With the SV7900 here, now you can have this report. The machine can show you, how was the ventilatory support, what was the asynchrony, index here, what was the risk of lung injury, and even if you win your patient, what is the risk of failing or success? You can get all these reports and print them. So for research, for academic purposes, it's very interesting. Okay. So, and now it's going to be modular. You can put your CO2 here, even SpO2, and then have the waveforms. And if you want to assess the nutrition, we can do metabolic assessment with energy expenditure and respiratory portion here. And even the EIT now can be added to assess how is the pressures regional, not to just focus on the global parameters. So I was talking about the smart ICU. Yes, for the smart ICU. Now we've got this ventilator here. So with the monitor, with the pumps here, everything can be integrated through Wi-Fi or wired internet to the central station. And now that's why when it comes to winning, this ventilator can know what came from the patient monitor. How is the SpO2? How is the hemodynamic status of the patient? And then it can tell you now the probability of making it if you win this patient is like this. So, and when it comes to silent ICU, since we have that central station and Connect technology, we can off all the alarms in your ICU and see everything on the central station. So this will even reduce the risk of delirium in your ICU here. And with mobile viewer, even if you are here, you can, on your mobile viewer, you can see how your patient is doing without being in the hospital, thanks to this Connect technology. So this is how we can design your smart ICU, making it silent, know when to win the patient, reduce the complications and the cost. So thank you very much for the time. I don't know if there's any question, or you can reach out to the booth and then we talk about details. Thank you very much.
Thank you very much. I'll quickly call on the Drager representative. Come to the front. Please come.
Financing, the name of the slide.
What's the name of
So used. Pointer is on the stage.
Okay.
Is it on the stage?
Yeah.
Press once. Good.
Yes. Let's go.
So raise volume, mic. Yes.
All right. Good evening, because it's evening already. Thank you very much for the opportunity to make this presentation. Interestingly, with the panel session that was supposed to come before the presentation in the schedule, I was happy to hear a lot of the feedback and comments in mentioning Drager and also in talking about financing solutions. And that's because there were people in the room already who we are having these conversations with and providing these solutions that I'm going to talk about. In many instances, we see to provide sustainable ICU and intensive care services, and we need to add financing into the conversation, because intensive care is certainly a capital intensive and a high financing requiring venture. And considering that, so we are also trying to look at how we can be able to provide that total overall solution to clinicians from Drager. Due to time, I would not take so much time to talk around what we do at Drager, because I know a lot of people are familiar with that. But we believe that increasingly, for us to provide holistic solutions, we need to be able to connect devices together. And everyone globally is talking about that. And our leadership with the SDC platform, we believe, is providing that future that a lot of companies are currently also jumping on. Our solution in the intensive care environment covers not just devices that are able to provide clinical care and optimize the care that you are providing to the patients, but also creating a workplace environment that provides healing that is adequate for intensive care to ensure that the outcome from the care is well optimized. And of course, managing data increasingly, having it readily available at the bedside and at different points that care is being provided. And of course, making the ICU stressless or stress-free as much as possible, considering the reduction in the workforce with the Japa syndrome and a lot of other talent flights that you have. Then being able to reduce the challenge that people are having with documentation and administrative tasks becomes important. And we are able to create the right environment that is required for healing. So in doing that, we are able to provide not just clinical application expertise, we are able to start from the design and the consultancy in creating that environment and in supporting you with those projects that you are looking at from the beginning to the end, and then getting to the point where we then execute with installation and support. And then, of course, everyone knows Draga when it comes to education and providing services. We are trying to ensure that we are able to provide those holistic solutions to you in creating the right intensive care environment and practice. Now, I will also not take time to talk about the financing challenges, because yesterday, I believe there were a lot of talk on that topic, and also this morning. And that affects the different stakeholders that we have in that environment, and is a concern both to the clinicians, to the administrators, to the biomedical engineer. It was also interesting to hear the question at that point towards the end of the conversation in the morning or at noon around skilling biomedical engineers. And these are things that we have a lot of experience also even in Ghana on, that we believe are things that we can also offer to the market in Nigeria. So the financing models, we know based on experience and things that have been done in other markets that are similar to us in resource-constrained settings, we know there are a lot of challenges and factors that we need to consider and we need to overcome, from the funding, the cost of capital, the FX challenges that we have, the overall total cost of ownership, where in many instances people are considering what they pay now for the equipment, but not considering how long the equipment will last and how long they're able to cover the total cost of ownership that they have. And then the question also earlier in the morning around the creditworthiness of the businesses that people run and building the right business plan that is bankable, that people can be able to finance. Being able to help hospitals, intensive care projects to build those kind of competence, we believe would help us in being able to get the right financing and providing the right capital that is required in the market. We know there are different solutions that can be deployed, from PPPs to leasing, vendor financing, pay-per-use that people are using currently in the market. But we have solutions that we are able to offer from developmental financing, which I will talk about in the next couple of slides, and also with export credits backing that is possible for buyers that they are able to access and we're able to explore. So here, this can be including international financing and also domestic financing that are possible. Now, with the international financing, as a German company, we're able to have financing from German financing institutions that are able to provide buyer credits to projects that clinicians and hospital administrators are trying to administer. It's largely a 3- or 4-way financing structure with 3 key entities. So the person who is importing, this would be either the hospital or an entity in Nigeria, which you can partner with. So either maybe with our sales channel partners or with other partners that you have and you are familiar with your institution. So they would be our importers or the borrowers that we would work with. Then we, the exporter, would get the financing entity that is able to provide that financing. And to guarantee the financing, then we have the Eulehemas, which is the German Exim, equivalent of the Exim Bank, which would then be able to guarantee that credit. that will now play. So generally how this happens would be there's a relationship between us and you or your partner that is domestic. We provide the solution that is required, both Draeger and non-Draeger, for the whole project, preferably one whole PO with everything required in the project. Then you would usually provide about 15% commitment to the total amount that is required. The equipment and the solution is delivered to you, and then the financing institution then builds a repayment plan between you and them. Now, the benefits that you have and the institutions that we are currently working with, FIB, AKA Bank, they have different sizes of projects that can be financed. So here with the FIB, they do what in Europe we call the small ticket items. So here is as low as 0.5 million euros. The AKA usually would start from 1.5 million euros. The tenure is usually from 2 to 8 or 10 years, depending on which bank and depending on the size of what you're looking for. The currency is in euros or in USD. So that's where there is a challenge with the FX that you would need to consider. The interest rates are largely between 3, depending on the size, to 6. In most of the hospitals that we have offered within Nigeria, they're usually at 6% interest rate. So we see single-digit interest rates that are possible compared to the 30, 28 that we're seeing currently. And the cover is from the Euler Hammers. And then we have other options where we are able to offer in Naira. This is from Odo and from some other financing banks, Access Bank, Sterling Bank in Nigeria. Now, the requirement is what they will need is at least they need a business that has been set up for at least 3 years. We will define the scope of what you need, and then we will then agree on how this would be executed. For the other one from Access Bank, this is supported by the German Development Bank, the DEG, which is the Trade Connect facility, which was just launched recently in Nigeria. Here, they cover 50% of the loan required, and that then gives you a longer term, it gives you a larger volume that is possible for us to be able to execute. So if you are interested in these or your hospitals, you think these are solutions that we can talk to them about, then please reach out to us and we can sit down and look for the best solution that meets your need. So thank you very much for the opportunity and for the attention.
Thank you very much. We will reach out to you when we need the financing. Thank you. Well done. I'm going to call on Hilmed.
Are you not presenting for them slide? Yeah. Okay. Let me project first 1 minute. Any audio in the slide? Is there any sound in the slide? Press previous once. Press once. Forward. No. Forward once. Then back. Back. That's once.
All right. Good evening,
The next one.
professors and colleagues here. I want to start on the existing protocol just to speak on behalf of here Aeromed. Okay. So So the Ailmed company has been there since 2001, and then it has core concept of independent innovation. Okay, trying to lead in the development of a medical industry. And then it has done this by venturing into medical ventilators, anesthesia machines, sleep ventilators, medical oxygen, and all the rest of them. Okay, so, and this it has tried to do by expanding so fast that within just the few years, it has reached about 160 countries and the regions of the world. It has special focus to position itself by being the world's leading medical device manufacturing enterprise with a vision of becoming an expert in the anesthesia and respiration with devices. So it has core value of providing reliable products with thoughtful service. Okay, so sometime 2019, Ailmed decided to merge with a company called Here, a German company, and that was a merger between quality and innovation. Okay, so Ailmed, because of its plan and aims and objective to be able to focus on core innovations and expanding in the medical industry. Okay, he made another company called Here, and both of them merged. And the aim was to be able to provide quality products. And this was exemplified by the year 2019, during the COVID-19. Okay, the Here Ailmed were able to be among the 100 private entrepreneurs to be able to provide and supply a lot of ventilators during the COVID-19 pandemic. Okay, so Here has been there for over 142 years, okay, with its plans for great innovations driven by customers' needs, not just to provide anything, but what the people need. And it's been focusing on success, which depends upon great innovations. So it has expanded to the field of anesthesia workstations, surgical suites, oxygen generations, multi-parameter monitors, mechanical ventilators, infusion therapy, and other products. Okay, as we can see here, we can see a lot of products ranging from anesthesia machine and all the rest of them. Okay. So in terms of theater equipment, the theater lights, theater tables, okay, Ailmed and Here has been doing a great work there, even the pendants and designing of theaters and ICUs. Okay, so syringe pumps, infusion pumps, and the cath labs, the special monitors like the infrared, cerebral oximetries. Okay, the company has been doing so much there, but I have special interest, and that is why I am somehow here this evening, to talk about a brief introduction to the machine VG70 ventilator, which the Here Ailmed has been able to provide. And the machine has been doing a great work, okay, for us. Okay, so what are special things about this machine? It's built in low noise turbine, okay, that it can be there providing services very silent, and it's very much durable that it can work for a lifetime of over 30 hours. Okay, so, and it can also function to be used for both pediatrics and adults, with even some of them adapted for neonatal ventilation. Okay, so it can be applied because of its diversity. You can actually dismantle from the stand and be used like a transport ventilator, especially within the hospital environment. Maybe somebody is going for dialysis, somebody is going for CT scan or MRI. It can actually be adapted for such in-hospital transport. Okay, so these are some of the features. Now, one of the special things is about the presence of aluminum magnesium alloy, okay, for the ventilator. All right. Let me talk about why I am here essentially. Now, UNTH have had a great experience with this ventilator. In the year 2019, the hospital introduced what is called PPP. So when the machine was brought, when the ventilator was brought, about 6 of them, many of us saw the ventilator and we're all shouting, China, China, China. So we've heard machine is not going to last. But to our dismay, what was our discovery? We discovered that for the past 7 years, the machine had been very durable and rugged. Now, in the year 2020, during the pandemic, a lot of other ventilators were bought in the hospital. But I can tell you that the Ailmate VG60, not even 70 that we have, is still serving us. So it is durable and it is rugged and it can stand the test of time. Now, it is user-friendly. Now, there are a lot of ventilators that when you have, you'll be having ambiguity in trying to prime or calibrate the ventilator. But this is simple and user-friendly. The interface is sweet. And both technicians, nurses, doctors, anybody can operate it. Now, another important feature is the after-sales services and maintenance. I can tell you, for these 7 years, there have been beautiful services being done back to the ventilator that even up to now is still serving us. The spare parts like the oxygen sensors and batteries, when it is necessary for replacement, they are actually replaced without cumbersomeness. Now, pocket-friendly company and product. Now, what am I talking about here? The equipment is pocket-friendly. If you compare the price, compare the features, and compare the durability and rugged nature to other ventilators of its kind, you will discover that the VG70 or Ailmate ventilators is better equipped to serve you and in our environment. I can, okay, thank you very much. So I want to encourage every one of us, if you want a company to partner with, to provide you after-sales services, to provide you pocket-friendly equipment, you need to partner with Ailmate. Thank you.
Thank you very much. Thank you very much. Very much. We are going to be taking the last one from Pfizer. Thank you.
What? I'm back. Let's see. Good. Back.
Good evening, everybody. Standing on existing protocol. I have a little confession to make. My voice is proportional to my size, so please bear with me. All right. I'm here to speak on Pfizer. Now, there's a lot of thinking that maybe Pfizer is no longer in Nigeria and all that. I want you all to know that Pfizer is very much available in Nigeria through its partner, DP World. Worldwide Healthcare is a branch of DP World that deals with the marketing and sales of everything that has to do with Pfizer brand. In Worldwide Care is one of the African leading routes to market partner for pharmaceutical and consumer OTC. Let me not spend much time here. We are committed to deliver quality and genuine pharmaceutical product, supporting HCPs with trusted brand, webinars, and journals. Now, this is just some of our anti-infective, and I will just maybe speak on one or two of them. Meronym. For those of us in ICU, I don't think Meronym is a new product. It's something that we're very familiar with. Now, Meronym is the brand of meropenem. And being the brand, of course, we know it covers both gram-positive, gram-negative, and anaerobic bacteria, which makes it effective in ICU, especially when the causative organism is not known. It's also worth noting here that Meronym is available nationwide, and it's just about 18,000 per vial. I mean, for the branded product, I think that's a fair price. Also, I want us to know here that we are available to supply directly to the HCPs or to their patients if need be, because we understand that some institutions have problem with, buying due to depth and all that, but we are very much available. We're just a phone call away. You call on us and we can supply directly to you. Also, we have our Unacin, which is our brand of ampicillin and Suboxone for bacterial pneumonia, sensitized especially in neonates. Then we have the Allicin C ampoule, which is our brand of clindamycin. Now, it's a deep tissue penetration and very good for respiratory tract infection, skin and soft tissue infection. The Allicin C comes in 300 milligram, 150 milligram, and also in injections. Then we also have Eliquis, which is our brand for apixaban. Now, there are several studies that support the efficacy and the superiority of apixaban over Xerato and also over warfarin in treatment and prophylaxis of DVT and PE. Some of such studies are those done by Aristotle and also by Cohort. Then we have Zithromas capsule, which is available in 250 milligram and also in suspension for children. We have Tazocin injection, which is our piperacillin and tazobactam for severe pneumonia, abdominal infection, etc. We also have Zavicefta. Now, this is our pictorial form of some of our products. This is what Meronym look like, the branded Meronym. This is what Unacin looks like. This is what Diflucan looks like. This is what Eliquis look like. This is what Zithromas look like. And this is what Zavicefta look like. This is what Fen look like. Now, I am here just to reassure us that Pfizer is still very much available in Nigeria and is still dependable. Thank you very much.
Thank you very much for taking the time, Pfizer. So, on behalf of the President, Intensive and Critical Care Society of Nigeria, Dr. Joe Botokola, and the chairman of the LOC committee, we really want to appreciate all our partners for your support in this program. We really appreciate you, and we are looking forward to more cooperation. You can actually have us in your mind even right before we reach out to you. I think that will help us a lot. As you are drawing your plan for the new year, please include us so that when we reach out to you, it will not be a new thing. It will be what you're already planning for. So we are looking forward to more productive partnership with you. Thank you very much once again. So we will be going into the AGM. Please, I want us to move forward, please. All the members of the Intensive and Critical